that case, if there is no parking zone for doing the pot, so what is your strategy? Like in such case, are we supposed to cover the whole left main, or if you are planning to park the stent from the LAD ostium to the distal left main, there should be enough line of the stent strut so we can anticipate such kind of sequelae, we can deal it with the pot easily.
That's an important point, because we always keep enough stent to do a pot over there. And the smallest pot balloon is a 6. So we, but I think, what was the size of your left main?
8 millimeters. Because it was a 5, I didn't have a 5, 6, 5, 8. That's why.
Left main was very long.
Yeah. I had,
So she had significant left into the left main to do a pot.
I saw to it that my stent could hold a pot balloon. Okay?
That's the reason why probably the better strategy would be, Mama's saying, that when you have a doubt, go to a tap. So the provisional strategy doesn't mean single stent alone. Provisional means if you have a problem, you can always switch to a two-stent strategy. That's the whole idea of provisional. A stepwise provisional depending on what we get. So in this case, we have a doubt and we have a hematoma. The options are leave it alone or do a tap.
Yeah. Maybe on another day I would have done a tap. Maybe, yeah, we considered it for a long...
So this case illustrated...
So we already discussed all the points. Yes, there was some fatigue at the end, and I'm not sure.
Good.
What?
That looks good.
Right. No, there's nothing much we already... The angiogram I showed, sir. This and the next one.
We have a good angiographic result.
And a good angiographic result from LM to LAD.
Yeah.
Yes, I believe if you have a proximal LAD more than 8 millimeter square, definitely it equals to lima. I'm a strong believer. So in proximal LAD, you need to dilate with a 3.5 millimeter.
Good morning. Greetings from it.
Stop. Okay.
3.5 millimeter balloon will give you in vitro 10 millimeter. At least if you go to 80% of it, 80 millimeters with a 3.5, that's the target. We should be able to, the minimal stent area is very important. In proximal LAD, we should get at least 8 millimeter square in majority of the patients. Then only we can fight with a very formidable adversary.
LAD was not expanded. We re-expanded it with the cutting balloon. Then there was some...
I think we discussed all the points already.
So if there are no further comments, we'll congratulate Dr. Sujata for a wonderful case. Round of applause. And thank you so much. A lot of learning points. And that's how beautifully, when you do a case, you start with an upfront idea what you're going to do. But as it unfolds, as the beauty of the case unfolds, as imaging helps you along, you innovate. That's what makes a great case. Thank you so much.
Thank you. Thank my teachers. Both are sitting there.
Thank you so much, ma'am. Moving on, the next session is calcium session. I invite Dr. K. Damodar Rao sir, Dr. Ritu Bhatia ma'am, Dr. D.K. Barua sir, Dr. Sarita Rao ma'am, Dr. Ashalata ma'am, and Dr. Sandeep Bansal sir, PSS Chowdhury sir to chair the session. And the next speaker is going to be Dr. Anupam Goyal sir, who will be talking on orbital, what took it so long to come to forefront.
Hi, good morning, friends. Sorry, this is Madam, not Sir. So we don't have the first talk of the session, Rota? Right. slides there.
Can we have the slides, please?
In the meantime, congratulations, Dr. Sujata, Dr. Sarita, and all of us for this wonderful meeting. As soon as I have my slides, we'll be going ahead. So as we have been seeing in the meeting, calcium is a very important part when we take care of coronary arteries. So today's topic is about orbital atherectomy.
This is the wrong set of slides, please. Can you take the orbital atherectomy presentation?
By name of Dr. Anupam Goyal, you have it loaded with you. Right. So topic for my discussion is orbital. When we are doing coronary angioplasty, our aim is to have a good minimal stent area so that the stent can have good apposition, which is a predictor of long-term efficacy of the stent. Calcium negatively affects stent expansion, wall apposition, drug delivery, leading to inferior outcomes and high TLR rates. So we need to take care of this calcium before we go ahead with good results in our coronary intervention. Calcium is a predictor of worse overall PCI outcome, and as we know, despite all the advances in stent technology, moderate and severe calcification remains a real challenge for interventional cardiologists, and we need newer therapy to take care of it. The predictors of having a bad calcium in coronary arteries are a presence of prior CABG or PCI, known peripheral vascular disease, coronary artery disease, hypertension, dyslipidemia, AIDS, smoking, diabetes, and CKD. These are the common comorbidities which we have in most of our patients. So what it can show is that most of our patients are likely to have coronary calcium. Unfortunately, okay, is it better now? I don't know actually how to see my slides. So when we do an angiography, it underestimates the lesion and the calcium, but we can see the calcium with intravascular imaging in the form of IVUS and OCT so that we have an idea. And with intravascular imaging, we know that most of the coronary arteries have calcium. But when is the calcium enough to warrant atherectomy? This is one question we need to address. So while we are using IVUS to assess our calcium load, there is a calcium score of 1 to 4 with each factor calcium mark of more than 270 degree in a 5 millimeter length, concentric calcium, that is 360 degree arc calcium, a calcium nodule, and an adjacent vessel size of less than 3.5. Each have a score, and any score more than 2 means that we need an atherectomy before going ahead with angioplasty. When we are using rota, there is a simple rule of 5 to follow. Calcium thickness of more than 5 millimeter, more than 50% vessel arc, it means more than 180 degree arc of calcium, and a length of 5 millimeter means that patient would need atherectomy before going ahead with angioplasty. So what devices do we have available to us for calcium modification? Cutting and scoring balloon, intravascular lithotripsy, excimer laser, rotational atherectomy, and orbital atherectomy. Let's see what orbital atherectomy is. This is a prototype of orbital atherectomy which has a diamond back 360 degree crown. The pump is electronically worked, and there is a Viper slide lubricant which is essential for the patient. And this Viper wire advance has a flexi tip which is a much easier wire to use as compared to the rota wire. It's almost like our workhorse wire. And this device is 6 French compatible. There is a crown advancement knob like a rota, but good thing is it has 2 push buttons for speed at for 80,000 speed, which is the standard speed, and 1,20,000 speed, which is the high speed to be used in some cases. Orbital has only one single crown of 1.25 millimeter, which is enough to take care of the vessel size 2.5 to 4. And there is a guide wire break to stabilize the wire we are working on rota. Good thing is orbital has two mechanisms of action. It has an atherectomy by bidirectional differential sending by the crown, and there is pulsatile force from eccentrically mounted crown, which when it orbits inside the artery, leads to changes in vessel compliance and fracture of the deep-seated medial calcium. So this bidirectional sending, because of the all-around diamond-coated crown, helps in reducing the superficial calcium and gain in internal luminal diameter of the vessel. The differential segment reduces the calcified plaque with minimized damage to the vessel inside. The calcium particulate which are generated after orbital are very small, to the tune of 2 microns each. They are much smaller as compared to the RBCs and capillary size. So the chances of slow flow is very less as compared to the other modalities with orbital. The pulsatile forces which are produced by centrifugal elliptical orbiting of the crown help in making changing the compliance of the calcified vessels. There is fracture of the calcified nodules inside, and we are able to extend our stent better. A very important point, we have to be slow while doing orbital. The recommended speed is only 1 to 3 millimeter per second, 2 millimeter ahead, 1 millimeter back, to have a good outcome of the data. We know when we use the high speed, the lumen gain is much less as compared to when we go slowly. And slow speed helps us in maintaining the efficiency of the vessel and better control. We need high speed only if the vessel size is very high, there is significant calcium less, and we have to make sure the vessel is not very tortuous when we are using the high speed. This is how the orbital works. The crown rotates on itself, doing the intimal sending of the calcium, and then it has a centrifugal elliptical force by which it modifies the compliance of the vessel, leading to medial calcium fracturing and better control over the calcium. We can go forward and back, 2 millimeter, 1 millimeter, so that we achieve adequate sending of the vessel. It gives a very good result by going slowly, and the vessel is prepared for the stent and for the balloon. How is orbital different as compared to rota? As compared to monodirectional drilling in rota, orbital atherectomy has bidirectional drilling. There is only one single size. We don't have to change the burst size as per the vessel size, 1.2 millimeter, all around diamond encrusted crown, which takes care of all the vessels from 2.5 to 4. There are two standard speed, 80,000 and 1,20,000. For most of the cases, 80,000 speed is enough. Because of less speed, the thermal injury to the tissues is less. The power source is electronically mediated, not the pneumatic mediated. Eccentrically mounted diamond-coated crown uses centrifugally force to orbit, and then it causes change in the compliance of the vessel. The medial calcium is fractured, and the wire is much more easy to handle. As compared to rota wire, it's almost like our workhorse wire, easy to track the lesions, and the procedure can be completed even on this wire. We don't have to change the wire midway if we want to. And because of the small particulate sizes which are produced after orbital, the chances of slow flow is very less, to the tune of less than 1% of the patients. Where we should not use orbital, though it can be used even in these cases, but we need to be very careful. Relative contraindications are graft vessel, single living vessel, already implanted stent, presence of thrombus or dissection, and if the patient is allergic to Viper slide lubricant which has egg yolk and olive oil in it. What evidences do we have for rota till now? Orbit 2, we have results. Orbit 2 was a prospective multicentral single-arm study of 443 patients who had significantly calcified arteries. The primary safety endpoint was 30-day MACE, but the patients were followed over 1 year, 3 year, and 5 year. And what it showed is by its bidirectional acting. I mean, it does the calcium sending, it modifies the calcium plaque. So the results are almost as good as any DS result. The 1 year TLR was 4.7 and 3 years 7.8, almost to the tune of our standard DES, when it was used in severely calcified vessels which otherwise have worse outcome. ELLIPSE is a big trial which started enrolling patients from 2017. 2,000 patients have been enrolled across 150 US sites. They have been randomized 1:1 to establish the superiority of orbital between orbital atherectomy versus the standard procedure with specialty balloons. We'll have the results soon in fall of 2024 and we'll know further how is it doing. Orbital has proven safety profile. There is low rates of procedural complication. As we know from Orbit 2 trial and from 2 large population-based meta-analysis of more than 1,000 patients, that the procedural complications are very less. So it's a relatively safe procedure. This is a case I like to show, 60-year-old lady, diabetic. She came with minimal exertion angina. We can see there is tram tracking calcification in the arteries. LED has calcified critical lesion. So did an OCT to see the extent of the calcium to plan further strategy. And OCT shows an MLA of 1.2 with significant calcified nodules all across the LED with a long segment. There is 360-degree arc of calcium with a calcium thickness of more than 0.5 millimeter. So plan to have debulking with orbital atherectomy device. Slowly and steadily the LED had orbital atherectomy done. This is the orbital crown, which is not as good to see as rota, but still it's seen on fluoro and cine. So this is the OCT after the orbital atherectomy. We have a MLA of 2 millimeter, and the OCT shows significant reduction in the superficial calcium as well as fractures in the deep calcium, giving a good area, good note that we can now go ahead with a simple NC balloon and stent the vessel. 2 overlapping stents in this heavily calcified arteries. With a satisfactory result. So this is an OCT done after the angioplasty and stent. It shows a well-apposed stent across this heavily calcified vessel and a good result. There's the final result. So these type of heavily calcified arteries, especially the larger vessels where rota has its limitation and we don't have much to offer, orbital becomes a very helpful tool to take care of these. To summarize, orbital atherectomy is a useful adjunct in management of moderate and severe calcified coronary artery, especially in the presence of concentric calcium, nodular calcium, and in large size arteries. With its dual mechanism of action, it helps with better luminal gain as well as change in compliance of the vessel wall with better management of medial calcium, which gets fractured and helps us to get a better MSA and stent apposition. Thank you so much.
Very nice presentation, Dr. Anupam. So we have all been rota users and now we are all orbital users also. So one quick question, and that's for everybody in the audience. When are you going to upfront go for orbital or when are you going to upfront go for rota?
I think rota has been a helpful tool, but it has some major limitations. We can only go unidirectional. We have to be really careful it doesn't jump and gets barred. So comparatively, orbital is easy to use. We can go ahead in the lesion, do the atherectomy and come back safely. And then when the larger vessel is there, with the rota, you can use a bud of 1.75 at the most. What about a vessel beyond that? If we still have deep-seated calcium, we have to either use an IVL or we can use an orbital. It takes care of the medial calcium as well.
So I think that's a very important point for everybody. If you want one burr which is going to suit all vessel sizes, you take an orbital because it treats between a vessel size of 2.5 to 4 and it affects both the superficial and deep calcium, while with rota we were frequently able to ablate only the superficial calcium. Here we are hitting the deep and superficial, single burr to all sizes, no need to upsize your burr continuously because most cath labs you would have a 1.25 and a 1.5. 1.75 in
Is also
some
very
cath
uncommon,
labs, but
exactly.
then it's not possible.
Also, the slow flow is very less, especially in
Yes.
patients with LV dysfunction. It's so much easy to use.
I think biggest advantage of the orbital is that if you have a vessel proximal to mid, different sizes, so mid is around 2.5 proximal. I think same bar you can finish it up. That's the biggest advantage. However, I did see some slow flow. I think slow flow is less is not that correct because I have a very bad experience of having too severe slow flow. In fact, no reflow. I think that depends on what patient you are treating, especially in a patient with the ACS situation. Most of our patients are in the acute coronary syndrome. So in that case, probably still it can have a slow flow. It cannot have a slow flow with
I think-
orbital.
No, I think you have to go slow. You have to give time to the device
That is the
because
basic technique of doing this one, going slow.
Yes, you have to be slow.
In fact, another disadvantage of this orbital electric because it takes more time. You have to
It
go
will
slowly.
take time.
But that always doesn't kind of ensure that you will not have a slow flow. So you need to be little careful in that case. Still, you can get a slow flow. I had no reflow.
No, that's all right. I mean, we can have, but when we compare the technology,
It is definitely
it is less than 1%.
professional electric.
What they say is rest between the therapies. After 30 seconds, give it rest more than 30
Exactly.
seconds.
That is the basic technique. You have to wait and do it.
Exactly.
Another, I think, area still not being investigated in Orbit 1 or Orbit 2 study because you have to be very careful when you tackle the osteal lesion. Osteal lesions, we don't have much experience of the orbital electric with osteal lesions. And the technique is also totally different. You cannot go upfront in antegrade direction. Maybe it will be more safer you cross this, the lesion than come back in a retrograde phase. In the osteal situation, I think we don't have much experience, so that needs to be investigated. Probably eclipse studies and all the matter going to include, I think, probably
For
osteal lesions.
orbitals, I think orbital is going to be better than rota because it's bang osteal.
Yes, exactly. But still you need to be careful because there is a chance that main artery can dissect.
So I think both these points are very interesting that you brought it up. First, regarding the slow flow, which you said, the basic principle why we have slow flow is because of the particle size. And the particle size in an orbital atherectomy is much smaller. It's smaller than the size of a red blood cell, which is why slow flow is less. Second, orbital compulsorily, it will give you a beep at 25 seconds and you stop. Many times when we are doing rota, we had that tendency that we would keep on burring. With orbital, it beeps and you stop. Second. Third is, after every run of orbital, we need to give dilators and wait for that compulsorily 30 seconds. In my experience, I didn't have slow flow. So I was very happy with that, one. And with rota, we frequently had slow flow. We've all had those situations. So it's the pathology behind it that because the particle size is small, so we have less slow flow. The second thing is in orbital lesions. I did try a couple of osteal lesions, and the best advantage of it is because it burrs backwards. So like we were discussing just now, that you cross the lesion and then burr backwards. It's very safe to burr backwards, and that's where the advantage of dual forward and backward cutting comes in. And because it can burr or orbit actually in both directions, so the chances of your burr getting stuck is also very less. So that's, thank you so much for a wonderful presentation.
Thank you. Thanks.
Should we go to the next one? We'll call Dr. Richa Sharma. She's going to speak on IVL. Is it sheer prematurity or a magical quiver full of arrows?
A very good morning to the full house and all the chairpersons. So I have been given this topic of intravascular lithotripsy. Is it a sheer prematurity or magical quiver full of arrows? So we'll be talking briefly about it. We have already discussed the technical complexities and implications of lesion with high coronary calcium. Role of intravascular imaging, Anupam ma'am has greatly told about the scoring with the intravascular imaging. And now calcium modification techniques that we have the armamentarium with the scoring balloons, cutting balloons, with the orbital atherectomy, rotational atherectomy, and intravascular lithotripsy device. Which to use, where to use. So we'll directly go upon the cases actually. So we know that traditionally rotational atherectomy used to be a predominant strategy for lesion with heavy coronary calcium, but now with the advent of new technologies and imaging modalities to assess the calcium, better understanding of how each modality works and where to use which modality, it has helped us to deal with these rock boulders and achieve the optimal results. This we have already discussed. This we know that based on intravascular imaging, what kind of calcification we can get, eccentric calcium, concentric calcium, or a full ring 360-degree calcium. The depth of calcium can be assessed. We all know that the deep calcium is not the one which affects the stent expansion, but it is the superficial calcium with a thickness more than 500 microns, which actually affects our stent expansion. Then the length of the calcium is definitely responsible for our optimal results, and there we have to work upon all these things. So calcium modification can be done either by ablation or by balloon-based technology, and these balloon-based technologies, they do not remove the calcium, but they aim to increase the plaque elasticity and allow the stent expansion by causing the cracks in the calcified component in one or more planes. And that we have to assess on the basis of fracture in the calcium on intravascular imaging. What are the limitations and risks posed by the current technologies of non-compliant balloons and atherectomy devices? High-pressure balloons, they preferentially expand away from calcium. They go onto the non-calcific side of the vessel, and they have limited effect on eccentric calcium. These may lead to further ruptures and perforation of the vessel if they expand totally on the other side of the calcium. And balloons are typically unable to modify deep or very thick calcium. Atherectomy, we all know that it has got a steep learning curve compared to balloon-based therapies, and ablation is contact dependent. We may struggle in larger caliber lumens. We may have to take a 2O burr in larger caliber lumens. Maybe in a left main calcium, you may have to take a 2O burr. Otherwise, you cannot even touch that calcium and cannot ablate it. Then it causes thermal injury that leads to increased risk of clotting. We have already discussed slow flow happening with the rotational atherectomy. It is unable to protect the side branch with a second guide wire, and potential to transect the wire and leading to larger dissections, perforations, distal embolization may happen. So these are certain risks and issues associated with non-compliant balloons and atherectomy. Now, shockwave IVL is not new. It is quite old now. It's an armamentarium in our shelf. We have shockwave, so it makes our life easier, makes our job easier. So I'm going to just show this case. He was a 76-year-old diabetic hypertensive male who presented with ACS non-STEMI, and his echo was suggestive of an ejection fraction of 30% with an inferior wall hypokinetic. His primary PCI to RCA was done, and later on he came for a stage PTCA to LAD and LCX. Now we can see that LCX was a very tight lesion. LAD was quite borderline, which we need to actually assess on intravascular imaging. So I thought that I'll first deal with the circumflex. 6-French right radial axis was taken, 6-French X-view was taken, and run-through was passed across the lesion. With a 2 or 15 mm balloon, I dilated the lesion at 14 atmospheres, but I could feel that there was some difficulty in crossing even a 2O balloon. So I straight away took a 3O10 Wolverine cutting balloon, because we all know that circumflex lesions are quite fibrotic. So at around 12 to 14 atmosphere, we dilated this 3O10 balloon. This was also crossing with some difficulty, and even after dilatation, when I tried to pass the balloon all across the circumflex, there was difficulty in crossing this. So now, and I could see now, initially I could not assess the calcium, but now in the distal part of the circumflex, I could see that yes, there is some issue, some calcium is there definitely, and now I wanted to do imaging in this patient. I talked to patient and I told him about the cost and everything, and we did the imaging. In this we have this Ultron 1.0, and in this imaging we can easily see that there is heavy calcium. This orange dot, which is showing in the L section, L mode, is showing that it is a heavy concentric calcium, which has not been broken up by even a 3O Wolverine cutting balloon. So now I need to upgrade my device at any cost. The thickness of the calcium was 990 microns, and it was a superficial calcium with an arc of more than 180 degree. So now I talked to the patient and sorted for IVL because I had no resort left. I could not do rota in this case. Already dissections have happened, and we all know that dissections are a contraindication to rota ablation. At this point, my only savior was intravascular lithotripsy balloon. OP and NC balloon, again, I didn't want to mess up with that, because already the vessel, I could see that it was expanding on one side, not on both the sides. It was an eccentric calcium. So after doing, we can see all these calcium with 155 degree, where the calcium arc was 86 degree, the depth of the calcium was 1140 microns, and it is a huge chunk of calcium which we need to break down. So we did IVL with 3 into 12 mm shockwave balloon for all the 8 cycles were given. And thereafter, we used a DES of 3 into 33 mm. The DES could expand beautifully, but in this stent boost, we can see that there was some under expansion of the stent at that very point of calcium, that was a very deep calcium. This particular point, as we can see here in the third slide. So I took a 3 into 10 mm NC balloon, dilated it at 12 to 24 atmospheres, again a 3.5 mm balloon, but I could see that my stent was going into one direction, so I just stopped and didn't over-dilate it with 3.5 balloon much. Proximal part was dilated with 3.5 mm balloon. This was the final result. I did the OCT assessment, and we could see that the stent could expand beautifully at that area also. There was no under expansion, and there was no calcium which was impinging on these stents. So I was pretty satisfied that yes, I have got a beautiful MSA and I can leave here as such. This was one application of IVL balloon in a case where I cannot use a rota ablation. I just had to use a balloon-based strategy because dissections has already happened. While into the case, I changed my strategy. This is another case, an 84-year-old female who presented with dyspnea and angina grade 3 since past 2 to 3 weeks. Her ECG was suggestive of left bundle branch block, and echo was having a 35 to 40% of EF with global LV hypokinesia. We did the angiogram of the patient, and the angiogram showed LAD lesion, which was not very much visible in caudal view, but in cranial view, you can see a tight LAD lesion. In iliocranial view, it was a proximal to mid-LAD tight lesion and a left dominant circulation. So I straight away went with imaging. I did the imaging, and here we can see, this was about the size. The minimal lumen area that we can see is 1.42, which it is shown by the software itself, and we could measure also, which was similar to what manual measurement and the MLAs were measured by software. Now this was the calcium. We can see calcium nodule in the second diagram, second figure, there is a calcium nodule, first and second, and then there is a 195 degree, more than 2 arcs of the calcium. So we definitely need to cut this calcium by either ways, either by rotational atherectomy orbital or by intravascular lithotripsy balloon. I tried to pass my NC balloon, and my 3O10 NC balloon could easily cross the lesion. So I thought that rather than giving any risk to this 84-year-old fragile lady, I will just do an IVL balloon in this case. After dilating with a 3O10 NC balloon, I did an IVL balloon of 3.5 into 12 mm at 4 atmosphere, and later on dilated with the same balloon till 12 atmospheres. Thereafter, my job was pretty easy. I did the imaging, I saw the calcium nodule, I did the cutting NC balloon and the IVL, saw the cracks and calcium fracture in the OCT post-IVL, thereafter implanted a stent. I parked the wire in the diagonal as well. A stent of 3.5 into 38 was implanted. Thereafter, this is not running. There is some issue with the view, I think. Yeah, this was the view. Thereafter, I dilated distally with 3.5. below the diagonal with a 4 balloon, and pot was done with a 4.5 into 12 balloon. I got a slow flow in my diagonal. I rewired the diagonal, dilated it just with a 1.5 balloon because I didn't want to go for any bifurcation strategy. Just a simple provisional strategy was my aim in this 84-year-old lady. This was the closure, abrupt closure of the side branch. I dilated and did a kissing balloon, again repot, and the final result was this was my final result. Did OCT pullback. Yeah, this was a post-test OCT run, which was, I think, some issue with the slides, technical problem. Yeah, the stent was adequately expanded with adequate MSAs. So not going into details of how IVL works, the system and everything. Just a point that we have to know that which calcium we are dealing with. We have to know the thickness of the calcium, which is very important, the arc of the calcium, and accordingly, we should choose our strategies. Safety issue versus therapeutic efficacy, we have been talking about rota orbital and IVL. Rota ablation, we know that it is a 0.4 to 0.6 Bur to vessel ratio. So it doesn't cut the thicker part of the calcium. It will just cut the superficial part. Then orbital for calcium nodules, what I have seen that it just jumps across the nodule and doesn't ablate that particular portion. For IVL, it works both on eccentric and concentric calcium. We have seen the nodular calcium breakage also with IVL. That's what I learned from my journey of IVL also. Initially, I was not able to break it with IVL. And then it's always a combination of therapy. If calcium thickness is more than 500 microns, either rota cut, orbital cut, IVL with a 1:1 NC balloon or a cutting balloon should be there. One should trust the therapy and prepare the lesion well. And heroism is in simplifying the procedure and not posing the patient in danger. And perseverance is the key for such calcific lesions. Thank you.
Great case, Dr. Sharma. I think you have shown a beautiful case of effectiveness of IVL in eccentric lesion.
Yes,
Eccentric
yes,
calcification. This is the biggest advantage of a simple technique, but you can treat eccentric calcium, nodular calcium, which is very difficult in cath lab. So I think this is the biggest advantage. Simple way you can treat, only maybe you will have to give more pulses in that particular point.
Yes.
So maybe C2 plus will be more useful in that kind of situation. One small question, how we select the IVL balloon?
conventional balloon. We are creating less trauma. We are creating a controlled dissection of the vessel, so less trauma to the vessel, which translates into a lower restenosis rate and lower MACE rates. So we have long-term better outcomes. So basically the balloons facilitate modification translating into good long-term results post-stent deployment. So what are the properties? The special balloon must deliver or reach the target, must pass through the target lesion or stent multiple times if needed, and must safely open the target. So what are the balloons which are available? Cutting balloon and the scoring balloon. Both these technologies create controlled incisions at low inflation pressures, at potentially increase the vessel compliance, and they thereby final stent expansion. As we know, OPN balloon, we operate at a higher pressure. Cutting balloon is basically a special balloon catheter with 3 or 4 atherotomes, which are bonded longitudinally to its surface. It's mounted on a special, semi-compliant balloon. It has a platinum marker to place the balloon optimally. There have been, the commonly used is the Wolverine balloon. It has improved deliverability and reduced profile. It is even 5 French compatible. It has a 0.1 height, working height, so that it cannot cause vessel dissection or perforation. As compared to the scoring balloon, Wolverine balloon, it cuts the surface of the vessel, whereas the scoring balloon scores the surface. Wolverine balloon cuts the lesion better than the scoring balloon. This is OCT, which shows that we are creating controlled circumferential calcium fractures. It cuts and fractures the calcium. So this is seen beautifully here in this picture. And ultimately, we see that MSA is more at the end of the procedure. So when we use the cutting balloon, there are some tips and tricks. We should dilate the lesion before taking cutting balloon. Select the correct diameter, not more than 1.1:1. For vessel sizes less than 3, we could use 1:1. And it needs to be undersized for calcified vessels. It is safe to use the cutting balloon post-rotablation, but it is useful for only short length lesions, not more than 20 millimeter. And the pressure should not exceed 12 to 14 atmospheres. And we should concentrate on the inflation and deflation technique. Slow inflation and deflation is required. Dial up 1 atmosphere for 5 seconds. Average inflation time should be 90 seconds per inflation. And average number of inflation is 1 to 4. Initially dilate at 6 atmospheres, and if waste still persists, go up to 12 atmospheres. And avoid dog boning. Coming to the scoring balloon, it is again a semi-compliant balloon with external nitinol-based wiring. So basically, it is to have a focused ablation of the lesion. It is a nitinol cage on a semi-compliant balloon. We have some key design enhancements. This is basically to maximize the crossability with a smaller, more flexible tip. So you have an improved lesion entry, and tip friction is reduced. And advancement force is also 40% less than the Wolverine balloon. The same principles hold good here. Balloon to artery ratio not more than 1.1:1. Inflation, deflation, there is a difference. Here it can be dilated relatively rapidly, or it can be deflated as compared to Wolverine. And average inflation time is around 60 seconds per inflation. Average number of inflations is 1 to 4. We can dilate initially at 8 atmospheres, and if its waste still persists, can go slowly up to 16 to 20 atmospheres. And we need to avoid dog boning. So, and one size balloon can be used for different vessel sizes. So it is useful in multivessel disease as the angiosculp grows at higher pressures. When we look at the predictors where we can use cutting or scoring balloon, the calcium thickness should be less than 0.2. Suppose we have a higher calcium thickness, we need to rotablate or use the other modalities before we use the cutting or the scoring balloon. When we compare both the balloons, they have entry profile or tip length, crossing profile, almost similar. Both are semi-compliant balloon. Balloon profile, and it has a folding technology which is helpful in smaller vessels, and it has a platinum markers which helps us in placing the balloon optimally. It shows less than 10% growth even at high pressures, as high as 40 atmospheres. This is a big advantage. There is controlled growth of OPN balloon which doesn't allow it to dog bone. Hence, it reduces the chances of perforations and dissections. The balloon is highly non-compliant, and the nominal pressure is 10 atmospheres, but a rated burst pressure is 35 atmospheres. The balloon diameters currently available are a range from 1.5 up to 4 millimeter. The choice of guide wire is important. We have to avoid using OPN balloon when we use polymer sleeve wires. For pre-dilatation, we need to undersize the balloon. For post-dilatation and for treating ISR, 1:1 size is recommended, but we need a special inflation device. It can be inflated as usual to up to 20 atmospheres. From then on, we have to go gradually every 5 seconds to higher pressure, and we need to check the balloon expansion in orthogonal views. And it is most useful in under-expanded stent. I can show you a case where post-stenting, there is under-expansion of the stent, and using an OPN balloon, it looks adequately expanded. Its use in the calcified nodules really requires attention. It works well when there is circumferential calcium, not when you have an eccentric calcification. And it can be also used with other plaque bulking systems. What is the evidence for OPN balloon? There is a large retrospective study of 326 patients where more than 90% of non-dilatable calcified coronary lesions, it was successful as compared to conventional balloons, where conventional balloons failed. But coronary rupture was noticed in 3 patients. We have an Indian study, which is an observational study, where 71 patients were studied. In that study, it was mainly used in post-dilatation alone, so around 63.2%, and 2 deaths noted due to coronary perforation. And this is a randomized study where it has been studied versus the scoring balloon. This OPN balloon has increased the minimal luminal diameter and reduced the diameter stenosis without much difference in terms of angiographic success. But when we look at this meta-analysis which was published in 2023, they conclude that modified balloon before stenting does not improve clinical or imaging outcomes compared with control therapy. So we are mainly looking at the increase in MLA, which should affect the long-term success following stenting. To summarize, I would like to summarize that special balloons are an ideal tool for plaque modification. Both scoring and cutting balloons they cause controlled calcium fracture at low pressures. With OPN balloon, we operate at a higher pressure, and they can be safely used along with atherectomy devices in densely calcific lesions. Thank you.
Thank you, Dr. Nagavani. Excellent talk. I think these balloons are more useful for the beginners when you have a calcified lesion. Just assess the calcifications angiographically, although it may be difficult, but still you can have some idea. If you can do the kind of imaging, if score is less than 3, then maybe these balloons will be very useful for the calcified lesions. If score is high, probably you have to go for atherectomy device, then followed by use of these balloons. And especially in osteal lesions, I think cutting balloons and scoring balloons are very useful.
Yes.
And nowadays, drug-coated balloons are coming out. Probably you can do the osteal lesions, open with these balloons, and we can deploy some drug in that osteal. I think that should be enough.
Especially Takayasus arthritis cutting balloon will be highly fibrotic lesion. It will be highly helpful.
Is there any comparison between at atherectomy, rotational atherectomy, and these balloons, any study? So because this is easier for any beginner or anything compared to atherectomies. So any comparative study, and if it is with good results.
So this is used in a different...
all are calcium modifiers.
But these are for superficial calcium. If it is more than 0.2, this is not recommended. You have to do atherectomy and follow it up with balloons.
For your answer, I think we don't have a head-to-head, these balloons which are atherectomy devices. We don't have that kind of study as far as I know. But we do have, preparing the lesions after rota, using a cutting balloon and OP-NC balloon. Recently published the RotaCut study from, I think, USA, Samir Sharma group. He published over 50 cases in Euro interventions just maybe a few months back. So they did the rotablation, followed by one group a cutting balloon, other group is OP-NC balloon. So they found there's not much of difference in terms of MSA as well as in terms of MACE. So message is that maybe both balloons are equally good, cutting as OP-NC, because OP-NC you have an advantage, liberty of going to high pressure. It's the biggest advantage of this one. Of course, cutting balloon is a controlled dissection so that next balloon is easy to inflate the lesions. So that is the only study what I can I know so far between the cutting and this OP-NC following the rotablation.
So I think the balloons have a very important place in our calcium dealing armamentarium, because first of all it is low cost, it can be reused, and generally most cath labs will have all sizes available to fit all the size of the vessels. So they have a great place in the armamentarium and they are very easy to use. So cutting balloon up front, scoring balloon up front, and with OP-NC it's a wonderful balloon because of its twin layer technology, that even when you go high pressure, the chances of perforation are very less because the balloon doesn't upsize itself, right? And there's literally no dog boning in that balloon. And not only do we use it pre-stenting, but many a times if you don't have imaging and your bed preparation has been inadequate and deploying a stent over there, is many a time stenting also to optimize the results. Yes, bed preparation always has to be final, but after that, many a times the best of the operators sometimes get stuck, and OP-NC has helped us to bail out many a.
Remember that these balloons cannot kind of fracture the calcium. So the action of the balloon is that, so it will act more on the non-calcified area rather than in the calcified areas. So it will allow the artery to expand, but not necessarily that it will fracture the calcium or modify the calcium. That is a little disadvantage, because in that case, maybe you can have more of an eccentric orifice, which we don't want in lesions. So in that case, that is the reason probably if you have high calcium score, always do atherectomy for of these balloons. Thank you very much.
Balloons are improving, even IVL is coming in. Can it any day replace? Because technologically, doing is more easy with balloons compared to atherectomy.
So there's always going to be lesions which are going to be balloon uncrossable. And that's where atherectomy will always score over a balloon-based technology, because we frequently come across balloon uncrossable lesion, imaging uncrossable lesion, and that's where the role of atherectomy will never go away.
Complementary, there is no perfect tool right now we have where we can use all calcified lesions. The replacement is difficult, maybe these are all complementary.
So we'll move to the final talk in our session. That's by Dr. Annapurna Kalia, Rotatripsy, the Final Frontier.
Good morning, dear friends, beautiful ladies and esteemed panel. At the outset, I would like to thank Dr. Sujata for giving me this opportunity to be a part of this academic feast and such an excellent conference. Today, I'm going to talk about road frontier. Change the slide. Sorry, my slides are not changing.
Technical support, can you please help with the slides?
No, it's not happening. Doesn't matter till that time. So basically, clinical coronary lesions with high calcium content, they pose a great challenge for us interventional cardiologists, and sometimes it can become a nightmare. Though, why is it so? Coronary calcium, if it is mild to moderate, we can easily, madam spoke about just now. But however, if you have moderate calcification and end length, like almost the calcification that we see on the diagrams, then we have to have multiple evolve strategies. We have heard today talks about orbital atherectomy and IVLs and balloons. But why do we worry much about bulking the lesions before going ahead with the stenting? The reason is, if you leave the calcific plaques before stenting it, there are major issues. One, standard deployment, that is under extension and stent malapposition. And that mainly poses the risk of future events and poorer clinical outcomes in terms of stent thrombosis the next few days or stent restenosis. So the clinical outcome goes hand in hand with the lesion preparation. So that's why it's very important to prepare these lesions well before implanting a stent. So now, how do I identify the coronary calcium? Traditionally on angiogram, but the sensitivity is much less, only 38%. And we have now more and more imaging techniques with which we can identify and also measure clinical calcium. These are the different modalities. CT angiography, excellent tool. You can localize, you can identify, and also you can quantify the calcium, but in the cath lab, you cannot use it. Grayscale IVIS, yes, excellent tool. We have been using it for quite a few years. Again, excellent for detection, localization. However, you cannot quantify the deeper calcium. Why? Because it casts a shadow. Radiofrequency IVIS with virtual histology. Excellent tool even for quantification of the calcium. But it's not available easily anywhere, in India at least. So we have this tool, OCT, which is excellent. My previous speakers have already shown the calcium. We can quantify the calcium. Debulking strategy would depend upon the calcium score. Now, clinically relevant calcium, as far as interventional cardiology is concerned, deep calcium, fibrous layer, and there is a deeper, thin fibrous layer, and thick fibrous as well as thick calcium layer. Superficial calcium and nodular calcium. Nodular calcium is usually associated with thrombus. It protrudes inside the lumen. Now, this was an OCT study to show, which tracking device is optimum for which type of calcium. So, because this study showed that here the calcium score, worse will be the prognosis in terms of reduction in increased MACE and reduced stent expansion. Here they take into consideration calcium arc. If one quadrant, 0 points, two quadrants, 1 point, and more than 180 degrees or more than two quadrants, then it's given 2 points. Thickness of calcium, more than that, then it's given 1 point. And the length of the calcific lesion, if it is more than 5 meters, then it's given 1 point. So total maximum score is 4. That is considered as the severely calcified artery and difficult to manage by PCC. This will come to our help in the next algorithm. So this is a rule of 5s. Sorry. The same thing. Now here are the debulking different strategies. My previous speakers have already spoken about orbital atherectomy, rotational atherectomy and IVLs. And there are different complications, and we know the outcomes, term outcomes seem to be all the three calcium debulking devices. This is a SHLOSA algorithm by Shlomis and Sosa for selection of calcium debulking strategy when we have calcium score. And this is a OCT based algorithm, sorry. You can see in the first panel, deep calcium, superficial calcium, and nodular calcium get a calcium score. If the calcium score is lower, then you go ahead and do balloons, what madam spoke some time back, NC balloons, scoring balloons, Wolverine or whatever, and then go ahead and place the stent, the results would be excellent. However, if you have very high calcium score, that is 4, and if this lesion is balloon crossable, then you can use IVL. That would be ideal technique. Do IVL and then do OCT after IVL. It's very important, because if the lesion is adequately modified, then go ahead and stent it. However, sometimes the lesions can be very high calcium score and balloon non-crossable. In such situation, as Dr. Sarita Rao sometime back said, you have to go ahead with the rotational atherectomy or orbital atherectomy to make the space so that your IVL, if required. So in such situations, you do rotational atherectomy, do IVUS again. If the lesion is not adequately modified, then add on IVL to this. This is what the rotatripsy we are going to talk today about. So this is a dual management, dual techniques done in the same patient for modification of superficial as well as deep calcium for facilitating the cross-it and to reduce the both the strategies together, then the results, the outcomes are much better. In rotatripsy, the calcium score would be 4. So what is rotatripsy? Rotatripsy is nothing but the drill disrupt. Rotablation helps you to shave off the superficial calcium. IVL will modify the deeper calcium. It's a synergistic effect of complementary techniques. It's specially ideal for coronary lesions with high calcium content, that is score of 4. As a bailout strategy, because most of the studies have shown, because it's not cost effective, so upfront is very difficult, so it usually is used as a bailout strategy, like you do the rotablation, but the deeper calcium, add on IVL. Or you start with IVL, you see that the balloon is not crossing, then you have to modify the strategy by taking down the rotational atherectomy, and later on you can do the IVL. Or sometimes you can use it up if you have got, if you are so much in doubt, or if possible, though upfront is cost little more costly, obviously, because you have to take permission from the insurance companies, etc. Now, the first case was published in, I think, 19 in Euro PCR by Roman and Garcia. That is what the first how we started with. Now, rotatripsy for severe calcified coronary artery lesions. The paper was published by Andrea Buono and Sandeep. This was from 4 studies from Europe, Italy, and UK. So they, they took all the angioplasties done in 4 studies, and out of almost 7,000 patients, approach, and they concluded that this is safe, and it's the success rate is with when you use these complementary techniques as bailout. This was another paper recently published, Mount Sinai. 21 patients, they took, they decided the strategy up front. These 21 had de novo calcifications, and 9 of them had instant restenosis, and some of them even had 2 layers of. So what was the outcome? The specificity, what they took in these patients, the artery size more than 3 larger bore arteries to start with, and they took us, they down 0.5, and they could go get 6 French. That was their aims and objective, that bore catheter, upfront dual debulking strategy, and smaller, ultimately IVL they use smaller vascular access. And they concluded that it is successful and quite safe. Registry from Singapore. Again, this included large study. These patients, out of 57 patients, 40% ACS. Many of them had dialysis. Many of them had, even they were on balloon. So, of all the procedures, 51% were successful, and there were some complication rates because this was a sick cohort. And they concluded that TRIPS was a successful in facilitating stent delivery and restoring flow even in sick cohort. This is the one case I would like to present quickly. Angiography, you can see heavily calcified proximal and mid LAD. Wired, since microcatheter was not going pre-dilated. Rotablated, 1.5 bar. This was a post-rota OCT run. And you can see at places the calcium is still thick, deep, and the MLA achieved was 1.35. So it is evidently after rota lesion not yet opened. Post-dilated 2.5 NC and decided to take IVL 3 by. So this was post-IVL OCT run. The calcium is nicely fractured. There are a lot of dissections and calcium cracks, and the MLA is 84. So went ahead and stented it, 338 stent. Post-dilated, this was a good result, and this was post-PCI OCT run. Here you can see there are no edge dissections, very important because distally the vessel was very in. And similarly, stent well opposed, and similarly no dissections. So there is another case. It's only, I'll just show for half a minute. Dominant RCA, calcific, distally almost like CTO, subtotal. Left system looks okay. Only thing is, good thing is there are some laterals to. Again, took filter FCY, did not go through it, and then over the microcatheter, took XTA. However, XTA exchanged to rotafloppy wire but could not cross the distal CTO segment. So changed the guide to Amplatzer, did rota 1.25, 1.5 bar, done. You can see decent OCT, you can see MLA still 1.3. So require further modification, calcium analysis, calcium, deep calcium. So decided to take and then stented it, proximal 3 and distal stent. So there was a reasonably post-dilatation and there was a reasonably good result. And this was a post procedure OCT. You can see the distal MS is 4.6, which is pretty good. So to cover, there was another case, but there's lack of time. So what are the key takeaways? Treatment of clinical lesions with high coronary calciums are extremely challenging. Poor outcomes due to stent thrombosis, due to underexposition of the stent, mainly stent thrombosis and restenosis. The pattern of coronary calcification will decide the prediction, the success of the procedure. Rotatripsy has been shown to be safe and effective technique, though there is limited outcome data because it's recently started last 4 years. The cost-effective challenge, however, nowadays in central government schemes, state government, they're allowing the as well as rota and OCTs, so we can give the benefit to our patients. Thank you.
Thank you. Nice talk, especially nice cases. This talk highlights the fact that we need to have more complementary device. No single device can be effective in all cases. So that is the basic message. Excellent cases.
Thank you. we are going to close the session in the interest of time. It was a presentation. Synergistic is the way to go. So rotatripsy, we only remember three things. One is it's a balloon uncrossable lesion, so you need rota. Second, it's thick calcium more than rota. And third, it's a large vessel, not work there. Thank you so much. Thank you to all the participants and the panelists.
Thank you. Thank you.
Stay on stage. The distribution right now. So, first the winners of the quiz.
Papers. So we had 18 papers which were presented. In view of time, we took some as oral presentations and some as the posters. The winners are E. Arunanandan. I'll send you a certificate, okay?
We have three first prizes. The second person is Dr. Harsha will take on his behalf.
Come fast. Her classmate.
Dr. Satish. Yes, Dr. Cicely will be collecting on her students'
Cicely
behalf.
is pretty excited that her students got the prize. She was behind me. Okay, nice. So keep inspiring your postgraduates and keep presenting papers and remember the IJCWD. Okay, next.
Then the prizes for the quiz. The winners are the Ruby team. Again, Dr. Arul Anandan.
How many?
Dr. S. Rajesh.
He's always winning.
And Dr. Rajesh Ponnada from Apollo Hospital, Visakhapatnam. Anandan and Rajesh from Chengalpet Medical College.
Maran and Hetancha, great job. So
Dr. Rajesh Ponnada is not here.
I'll take it.
Okay, the first runner-up, two teams were there. Dr. S. Rajnath and Dr. A. Shaktivela from Madras Medical College, Chennai, and A. Venkateshwara Rao from Apollo Hospitals, Vizag.
Come.
The second team as first runner-up, Dr. Abhinav Agarwal, Dr. Lavina Chandwani, and Dr. Shodhan Aital from Safdarjung and BMCC. BMMC.
I spoke with you, right? So you take, okay. She'll take on. Come. Oh.
Second runner-up, the Ember team, Dr. Sanjana from Andhra Medical College, Dr. Vijay Sharma and Dr. Rohit Bandhari from DY Medical College, DY Patil Medical College, Pune.
Yeah, they left. Yeah. The best case awards, the first prizes.
All three of them are first prizes only.
No. The best case awards. Monica Bandari, I think Radha Ranchi, first prize. Second prize, Monica Bandari. Are you there?
On rate control. Dr. Raman Rao garu to please come onto the stage to chair this session. Dr. P. Raman. Speakers, your time is 10 minutes each. We have 10 minutes, please.
Good morning, everybody. The time is already reduced. May we now request Dr. Kirtika to go on. Kirtika is a consultant physiologist, interventional cardiologist, and practicing also in Guntur. I have been working very hard in the field of electrophysiology. So
At that, I would like to thank Dr. Josna and Dr. Sujata for opportunity to present Wincar's program. My topic is optimal nutrition beyond drugs. It is lifestyle mass ablation. I have done lifestyle over ablation, which is my take-home message at last. How? Okay. See, this is like let case. A 64-year-old witness veins. Everything is okay except for limit. And the screening OS more than 30. He had he has AFib. First version was done with flicker. It was continued for the next 6 months. CPAP therapy. For 3 years, there was no heart failure, no AF on Holter. Case 2, a 23-year-old male, which is a common scenario, 12 beers on day, presented with AFib, immediate and managed with anticoagulation and drugs for the next 4 weeks. He abstained from alcohol and 2 years recurrence. See, AFib is the most common arrhythmia with lot burden. 4 to 5-fold increase in stroke, 3-fold increase in heart failure, 2-fold increase in dementia, 90% increase in all-cause mortality in certain groups. That certain group is geriatric group. This is a health threat because of increasing aging as well as obese population. There are few modifiable and non-modifiable risk factors. Age, race, ethnicity, and genetics are non-modifiable. But modifiable comes to all those which are the risk factors for CAD, like obesity, hypertension, diabetes mellitus, sleep apnea, coronary artery disease, heart failure, and alcohol and smoking. That gives us an opportunity for intervention at this level rather than going for ablation and all. Obesity, there are n number of pathophysiologies. Finally, it comes enlargement, that is, and autonomic tone abnormalities because it's a pro-inflammatory state. which associated with pericardial and epicardial fat that exerts a steric effect on cardiac ion channels that will shorten this pulmonary vein effective refractory period. This firing, which in turn increases risk of stroke, thromboembolism, and death, as well as recurrences after ablation. Risk is linear. With BMI more than 25 kg, there is 4% increase in risk of AFib. And meta-analysis showed that for every AF increase is up to 30% for every 5 unit increase in BMI. From 25 to 30, there is 30%, one-third increase in risk of AFib. Post-operative AFib increases by 10%, and post-ablation AFib increases by 13% with every 5 unit increase in BMI. These are few trials. Legacy would showed loss of 10% of body weight. We have 6-fold arrhythmia-free likelihood. And weight fluctuation of more than 5% with no stable weight gain associated with decreased AF recurrence. Reverse showed that from persistent AF, if the patient could maintain his BMI or weight loss to more than 10%, it becomes to paroxysmal AF or no AF. Arrest AF has shown that risk factor reduction has longer arrhythmia-free survival up to 4.8 times, 5 times likelihood to be in sinus rhythm rather than in AFib. SOS trial, bariatric surgery has had 30% lesser incidence in the occurrence of AFib compared to patients who didn't undergo surgery. And next risk factor is alcohol, which is totally a dose-dependent relationship. There is no safe limit. People say it's less than 3 drinks per week. There is no safe as coming to alcohol. It is direct relationship. How many drinks you drink, or you're not prone to get AFib. And the mechanism is shortening the atrial effective refractory period. Other potential mechanisms are on the vagal activity because it is not vagotonic. It is adrenergic. So there are 2 types of AFib. One is the vagotonic, the other is adrenergic. Most of the times these alcoholics, those who take a lot of alcohol, they have this adrenergic type of AFib, and they should be managed with anti-adrenergic drugs rather than adrenergic drugs, which are useful in the vagotonic of AFib. Abstinence, 6-month follow-up showed reduction in recurrence of the atrial fibrillation. That is one thing, as well as those who are into permanent AFib, they have lesser time spent in AFib compared to those who continue to take alcohol. Physical inactivity is an independent risk factor apart from obesity itself. CardioFit has showed that every MET gained was associated with 90% hernia recurrence. This shows that improvements in exercise capacity as small as 2, that is from one stage of treadmill to another stage. That's it. It just 2 METs increase in our exercise capacity can reduce our AFib up to 4 times. Regular aerobic exercise also improves the quality of life. Excessive exercise as done by these marathons, endurance athletes, it paradoxically increases the incidence of AFib and sudden cardiac arrest, which is a different topic by itself. So it is moderate exercise, like 150 minutes per week is beneficial, whereas extreme levels of exercise may be associated with increased progression of AFib. Another thing is mind-body exercise, which is equally important, like yoga and Tai Chi, because they mostly concentrate on the autonomic nervous system in AF genesis. Yes, there are vagotonic AFs, but still yoga had shown, it has shown to reduce these adrenergic AFibs and a positive effect. Comparative trial between high-intensity yoga showed that high-intensity training adversely affect the LA remodeling. Rather than going for high-intensity workouts, it is yoga and moderate exercise has shown that reduced AF episodes. And the other is the obstructive sleep apnea. Yes, both obesity and obstructive sleep apnea go hand in hand. But still, it is a independent risk factor. Those who are not obese, also those who are having AFib and we couldn't track the risk factor, one should go for this sleep study, polysomnography, to recognize the under-recognized OSAs, and once they get treated, these AFibs are under control without any drugs. They don't even need these pill-in pockets. OSA has similar mechanisms like obesity, apart from intermittent hypoxia, hypercapnia. They have similar mechanisms in the induction of AFib. Polysomnography is the gold standard for their diagnosis. OSA therapy is with CPAP and BiPAP overnight. That will reduce these AFib episodes. And it has... without appropriate CPAP therapy, AFib patients with OSA respond poorly to both pharmacological as well as non-pharmacological strategies like cardioversion or ablation. There are high rates of recurrence. Non-responders to antiarrhythmic drugs were more likely to have severe OSA than OSA, which is 2% versus 23%. Severe patients were more likely to be non-responders. Yes, diabetes is in itself is a risk factor for AFib. How it is associated with greater LV mass, wall thickness, higher pulse pressure, and stroke volume, which increases the arterial stiffness. Such chronic changes eventually lead to dilatation of atria and remodeling, electric and electromechanical and autonomic remodeling. Not only AFib, diabetic patients have more risk of these PSVTs compared to non-diabetics, and more risk of recurrences in diabetes rather than non-diabetic cohort. Taiwan study of 60,000 patients, metformin use was associated with around 20% lower risk of AFib over 13 years. Patients are going ablation also, they should be having strict glycemic control. Use of other SGLT1 antagonists have clearly reduced the incidence of AFib. Hypertension, similar also increases the LA remodeling, and it causes pulmonary vein trigger. Evidence suggests targeting BP2 guidelines will reduce these AFib recurrences as well as responder rates. Yes, paradoxically, alcohol increases AFib, but caffeine reduces. Meta-analysis of 23,000 patients identified a weak association between caffeine exposure and reduced AF risk. I mean, there is no strong association between caffeine and patients having AF. Though people, they complain like once they take a cup of hard coffee, they do have palpitations, but it is not so. The message is that regular exercise 150 minutes per week, HbA1c goal less than 6.4, target BP 130 by 80 mm of Hg, and polysomnography, drug non-responders, and CPAP whenever necessary, moderate alcohol consumption. Why all this is important in an era of, in an advanced era like this, where ablation is available? Yes, AF ablation is available, but it comes to cost and complications. Cost is very, very high. When I was trained on lasso catheter, which is nowhere available right now. We need to use this contact force, Pentaray, HD grid and all, which is easy to pertain all that for one patient. And recurrence rates. For one successful ablation, yes, how much is your success rate? It is around 60%. But when it comes to PSVT and all, it is more than 95%. And the other is centers of excellence. Yes, okay. Thank you.
Now I would like to get Dr. Aparna Jaiswal from 40 to deliver her lecture on conduction system pacing. Is it for all?
Thank you so much, the Winkas organization, and special thanks to Dr. Sujata, Dr. Jyotsna, and Dr. Sarita for having reunited all of us. I think the time has been a brief conduction system pacing and where to stand. I think it goes without saying that I think as cardiologists, electrophysiologists, there have been continuous quest for physiologic pacing, maybe about 70 years ago when pacing began. So the pacemaker, electrical-based pacemaker, and we had a VVI pacing. Subsequently, we had the rate response available. It went to VVIR. If you read an editorial by Dr. Richard Sutton, who's the father of syncope, he writes from VVIR, a physiological pacing mode, which was called triple DR. Imagine considering a triple DR a physiological pacing mode today. We understand with RV pacing is absolutely non-physiological, but that's how we've progressed. From a triple DR, we went to RV alternate site pacing because we realized it's non-physiological, and today we have CRT, we have conduction system pacing, trying to position themselves as the most physiologic pacing. We have understood from times beyond 50 years that the myocardium, which are activated early, contract early, and the parts which are activated late, contract late, trying to set the stage for the intraventricular conduction defects. If we were to see a normal population, 0.5 to 1.1% have left bundle branch, the normal population. But now, population of heart failure, intraventricular conduction defects are seen in about 30%, of which majority of them have left bundle branch block. Whenever patients have left bundle branch block, coupled with wide QRSs, we are well aware that they have higher morbidity and mortality. If we were to see what does RV pacing do, I told you while it was thought a triple DR is physiological, it is far from physiological. If there is one way RV apical pacing can give physiological conduction, it is provided that RV apical pacing in the pacemaker never happens. It should be only sensing a ventricle to let you know that RV apical pacing is by far one of the most non-physiological modes of pacing. We quickly moved in 1994, came a patient who had severe heart failure with a wide QRS, as much as 200 milliseconds with a left bundle branch block. I want to draw your attention. In 1994, today we are in 2024, it was drawn that in 1994, if we excited the left ventricle via this unique technique, which is very comorbid, we could probably improve the patient's morbidity, and nobody knew that we would also markedly improve the mortality till we had the trials. Then came the era of CRT, large number of randomized controlled trials done, but two trials which we must remember amongst CRT are the CARE-HF and the MADIT CRT, landmark trials. CARE-HF said that if you gave CRT-P to heart failure patients, not only you reduce morbidity, but you reduce mortality. Also, we realized from MADIT CRT was this slide, which one must remember, drawing your attention back to 1994, that select your patients with left bundle branch block with wide QRS for cardiac resynchronization therapy, because it is that subset which actually benefits from conduction system, from a CRT. So we all understood that, okay, patients with left bundle patients need resynchronization therapy, but I think those of us who practice in the field of electrophysiology have understood that no matter what we do, 30% of our patients continue to be non-responsive. There are several reasons, and the most important reason I would like to say is poor patient selection, coupled with inability to find the ideal vein wherein you find a good QLV. There are many other reasons apart from this. Also, we realized that biventricular pacing is still far from physiological. We know RV apical is absolutely far. We thought CRT would give us the answer, but even a CRT, a biventricular pacing, is far from physiological. Why is that so? Let me show you. Whenever you give a BiV pacing, an epicardial lead, pacing the epicardial veins, remember, the electrical stimulation has to go from the epicardium into the endocardium, coupled with scars which are present in the endocardium, which result in slow conduction coupled with this latency. Which brings us to something we've all been learning and excited to do, the His bundle pacing, which was first described that in 1997 there is a longitudinal dissociation of His. What does that mean? That this is what it means. So that's the AV node. The electrical conduction goes to the left and the right bundle. These bundles are destined very early, which is going to become the left and which is going to become the right. Now, when you have a patient with left bundle branch, you can see the electrical activation goes only up to the proximal left bundle, and then there is a block of the left bundle. If we go and pace distal to the block, you will be able to overcome the conduction system disease, and you will be able to offer the patient what today we call cardiac physiologic pacing. It has changed terminology over the years, but today we take physiological pacing. So this is to show you what comes closest to physiological activation of the ventricles. When you select and pace the His bundle, be it selective or non-selective His bundle pacing, that is as close you can be to physiological pacing when compared to any other pacing modes which I have described before. That set the stage, and it was in year 2000 that Dr. Deshmukh published a small series, and subsequent to that, there have been several investigators around the world publishing the data of His bundle pacing, followed by what I will just show you. So what you see on the left is a baseline left bundle. You see the center is a His bundle pacing. Now look at the transformation of the ECG. It becomes as physiological as it can be. Also what you can see is, look here in the lower one, you can see the electrograms, the HV interval, and when you pace the His, you see the electrical stimulus to the V is same as HV interval, telling active His bundle pacing. We realized that His bundle had certain limitations. There was a risk of lead dislodgement, increased pacing thresholds. Now these two elements are extremely important in somebody who is pacer dependent. Even today there are limited tools, but yes, the industry is moving rapidly. There are learning curve and challenges in anatomy with a poor success rate dealing with a patient who has AV blocks, which brings us to left bundle branch area pacing. Now, I want to let you know that when you do a left bundle branch area pacing, it obviates the problem of left branch, but you must understand, what does left bundle branch pacing mean? It encompasses a selective left bundle branch capture, a non-selective left bundle branch as well as LV septal capture. Remember, all these three are left bundle branch area pacing. How do I identify? Is a talk of different time, but yes, there are certain ECG criteria which allow you to understand, have I captured the left bundle? Is it selective? Is it non-selective? Or is it septal area capture of the left bundle? But sometimes we think that left bundle branch pacing implies that I have to capture only the left bundle, which is not so. So the conduction system pacing can be used either in a CRT as a primary strategy. We're not there yet, but yes, there are significant trials ongoing. Rescue, alternative strategy, those of us who are aggressively engaged in CRT feel very comforted today because we barely have to send our patients today for an epicardial implant. We quickly change the strategy and give the patient a hot CRT or a lot CRT. So this is just to mention that there were early studies in His bundle pacing for CRT, which began somewhere in the year 2013, 2014. We realized that there was no significant difference when His CRT versus BIV CRT was done. That means one lead in the bundle of His, one in the RV, one in the RA, or you could not an RV lead if it was a CRT-P. Subsequently, we had movement from the His bundle because we realized there were anatomic challenges, threshold challenges, to the patients to go into left bundle branch area pacing as a serving for biventricular pacing. Remember, the number of studies are small, randomized controlled trials are lesser, number of subject studies are less, hence it's still not a class 1A indication. So this is a level 80 trial, which is a randomized, a non-inferiority trial with 70 patients, and it was considered either give a CSP, a conduction system pacing, or give a patient a BiV pacing, and they wanted to see the LVAT. Remember, when you do a CSP, you look at left ventricular activation time, which is the activation time from the spike to the peak of the R wave in lead V5, V6, and ideally should be less than 100 milliseconds in low as well as high output. So this trial said that there was better with when patients were given conduction system versus a CRT. Now, this is a small study, which about, but this is to study the acute hemodynamics in a BiV versus left bundle branch area pacing. Subsequently, have been many trials. This is again a randomized trial, 6-month trial, but this is one of the important trials because they took non-ischemic cardiomyopathy patients and concluded that patients, when given a left bundle branch pacing CRT versus a BiV CRT, do just as good. In fact, they have better QRSs. Subsequently, there have been multi-center experiences with 230, 250 patients, but nowhere comparing to the randomized controlled trials, which I mentioned, like the CARE HF and the MADIT CRT. So now we've moved, I told you, when you do a CRT, but you identify that your QLV is not good from your LV lead, you don't want to depend upon that. You want to quickly change a strategy and do what we call left bundle branch pacing along with a CRT lead in the epicardial vein and give the patient a lot CRT. Thus, there has been a significant building body of evidence for conduction system pacing as CRT. That's been the mainstay, and this is a conclusion that when we gave CSP, there was significant reduction in the QRS duration, improvement in the ejection fraction. So where are we with the latest guidelines 2023? And one of the authors of these guidelines, we are privileged to have Dr. Vanita with us. I must confess that she's been a part of these guidelines. So the 2023 guidelines tell us that when you have a patient for CRT, it's a class 2A indication to consider. Even what's important that you must understand, if you have a patient for a pacemaker, now that's what the common garden variety cardiologists, all of us do. When should you consider in a patient for a pacemaker, when should you consider a conduction system pacing? You should consider when your patient is not fulfilling the criteria for ejection fraction is mildly reduced 60%. The class 1 for CRT, but needs a bradytherapy for pacing, strongly consider branch area pacing. The class of recommendation is class 2A. I will leave you for the want of time with this trial, and this trial will give us many answers, which is called a left versus left trial. It's also written on this trial. It's going to answer a $31 million question. So what's that question? It's going to tell us that if your patients have bradycardia, are you justified giving this patient RV apical, RV septal, or must give your patients a conduction system pacing with left bundle branch area pacing, which is this one. All of us know that in compromised ejection fraction, you want to give a BiV pacing. We know that adding a lead in the conduction system does well, but we are still, the quest for physiological pacing goes on, especially in this subset who have ejection fraction between 36 to 50%. Should you give them a BiV pacing or should you give them a left bundle branch area pacing to protect them from a complication which is preventable called pacing-induced cardiomyopathy, which I want to share is to the tune of 10 to 12%, and we as cardiologists cannot clearly know who will develop pacing-induced cardiomyopathy, but there are a few pointers which you should remember. One, if the anticipated RV pacing is more than 20 to 40%, he's likely to develop. Second, if the patient already has pre-existing LV dysfunction and give RV pacing, he may develop. Third, if the patient has functional mitral regurgitation, may develop. If the patient has a baseline QRS of less than 115 milliseconds or a paced QRS of more than 150, likely to develop. So this subset is likely to develop PICM. So bring conduction system pacing in your thoughts for that specific subset. With that, thank you so much for your patient listening.
Any questions from the audience?
introduce Dr. Neeti Chadda. Dr. Neeti Chadda is a senior consultant leading electrophysiology. She's currently associated with the Metro Group of Hospitals. Dr. Neeti is a very extremely accomplished cardiologist trained from SMS Jaipur, and we were fortunate to have her with us for a few years too.
Thank you, ma'am, for this very kind introduction. And let me confess, everything I know about EP is from madam, and I owe so much to her. Thank you so much, and thanks for the kind invitation to this wonderful session. The topic for PVCs, when and how to treat. And I should say this is a very, very important topic because PVCs are so prevalent and they can be serious sometimes. Somebody has to tell me how do you... Okay. To start with, the crux of the problem is that PVCs are so prevalent, but most of them are benign. So when to treat, when not to treat, when to just reassure the patient. So mostly you just reassure and let them be, don't touch, because they don't require any management. But there is a need to know specific red flags for PVCs because some of the PVCs may lead to sudden cardiac death. The natural history is benign in most, malignant for a select few. So the key pointers are whenever a patient comes to us for a PVC evaluation or with an ECG which has a frequent PVCs, the focus of initial evaluation is to rule out a structural heart disease. Idiopathic PVCs have a benign prognosis, but a PVC associated with structural heart disease may turn malignant. Treatment of PVC is indicated especially for the relief of symptoms. If first you try and reassure your patient, if reassurance is not sufficient, then treatment is indicated only for the relief of symptoms. When the PVC burden is high, which is like more than 10% of the total heartbeat, these need evaluation especially for systolic LV functions, and periodic assessment is required. Very high PVC burden, which is more than 20% PVCs heartbeat, they may require management. So whenever a patient of palpitation comes and we see that the ECG has PVCs, first is we assess the history of the heart disease or any previous surgery and evidence of heart disease on examination. If there is an evidence of heart disease, consider referral for further evaluation. If there is no history suggestive or examination suggestive of heart disease, and the symptoms are mild, don't do anything, symptoms are moderate or severe, you can add beta blockers or non-dihydropyridine calcium channel blockers, and that should suffice. So history is usually, we assess the duration of palpitations, any known history of heart disease like myocardial infarction, valvular heart disease, heart surgery, heart failure, all these has to be taken in the history. History of any medication intake, any dietary or health supplement, ask specifically for any supplements for weight loss or increase of energy levels because most of them contain caffeines. More pointers from the history. When do palpitations occur? Do they occur at rest? Do they occur at exercise? Is it in relation to the menstrual cycle? If they occur at rest, does exercise make them worse or better? So this is a very important pointer in a history. Does exercise worsen the palpitations? Are there symptoms of heart failure like dyspnea, orthopnea, early fatigue? Symptoms suggestive of myocardial substernal chest pain relieved by rest or worsened with exercise? Has a palpitation been ever associated with syncope or blackouts? History of unexplained death in the family. So all these have to be assessed in the history, and these are the red flags. If palpitations are associated with syncope, be alert of these PVCs. Exercise-induced palpitations have a worse prognosis. Known significant heart disease disease or heart surgery is, and family history of premature in a first degree relative, that is also very serious. Physical examination for significant murmurs, prominent S3 or S4, displaced or diffuse precordial heave, signs of left or right heart failure. I'm sorry, the previous, So all these signs on physical examination are red flags. If these are present, be very alert. These PVCs can be risky. Signs to look in the ECG, there is any abnormal or pathologic Q waves, any signs of acute MI or myocardial ischemia, prolonged QT, epsilon wave suggestive of ARVD, any ST elevation, especially in V1, V2, which is suggestive of a Brugada pattern. Further evaluation on an ECG or a Holter, we go ahead with either a 24-hour Holter monitor or an extended monitor, and we assess whether these are unifocal PVCs or multifocal, or they are associated with an NSVT or a sustained VT. Assessment of LV functions, echocardiogram is important, and exercise stress test is important to see if it's are related to activity or chest pain. So these are all red flags: multifocal PVCs, polymorphic PVCs, sustained VT, QT prolongation, any sustained or non-sustained VTs. Non-sustained VT with a normal LV functions normally have a benign prognosis. Idiopathic PVCs, so PVCs which are associated with a structurally normal heart are known as idiopathic. Roughly 60 to 80% originate in the RV outflow tract, typically present between ages of 30 to 50 years and more commonly in females, more common at rest and get better with exercise. Sometimes these can be associated with RV cardiomyopathy. These are not benign. Assessment of RV functions are as important as the assessment of LV functions in a patient. Cardiac MRI may be utilized if cardiomyopathy or cardiac sarcoidosis or suspected. So red flags for cardiomyopathy: multifocal PVCs or non-sustained, sustained VT of more than one morphology noted on monitoring. Syncope associated with active exercise, and imaging findings suggestive of cardiomyopathy or sarcoidosis or amyloidosis. When to treat the idiopathic PVCs, again, as I said, usually the treatment is required only to relieve the symptoms. If the patient is very apprehensive, you relieve the apprehension, give some therapy for relief of symptoms. Sometimes the patients can feel as little as 1 or 2 PVCs also are felt by the patients, and they are sometimes uncomfortable to the patients and they need treatment. To reverse the PVC-induced cardiomyopathy, so about 10% of the patients with high PVC burden may develop cardiomyopathy. So when the PVC burden is more than 10%, out of those also about 10% patients may go on to develop a cardiomyopathy, so the rate is low. Drugs of choice. The drug of choice is normal LV functions, beta blockers, or non-dihydropyridine calcium channel blockers. Deranged LV functions, beta blockers are the drug of choice. And failure of the above drugs to reach the desired results may warrant the use of class 1C or class 3 antiarrhythmic drugs versus catheter ablation. So as a note, catheter ablation is a highly successful procedure, especially when the PVC burden is high. Only a very small amount of failure rate is present. So catheter ablation is a procedure of choice, but preferably in patients with a high PVC burden. Presentation again is most PVCs are benign. No, they do not warrant any management. You need to know specific red flags for PVCs, and the natural history is benign and most malignant for a select few. Thank you.
you can give with more clarity. In an idiopathic PVC, what do you consider the patient?
So when the PVC burden is more than 20% or 25%, that is when the patient should be taken up for ablation, because procedure also it's a frequent PVC, so that you can those though with the system of you can actually cap even a single PVC and then do some pacing maneuvers and target them, but the best is to have a PVC burden procedure.
Yeah, so I think that's a very valid point, because emphasizes that there is no specific percentage that you should consider. A 4% or a 10%. What's important is symptomatic status, high PVC burden, which is probably giving rise to LV dysfunction. So you must looking at what is happening to the ejection fraction, especially reporting need that you may want to do. A point here is the chicken and egg story, that you want to know, is PVC causing cardiomyopathy or is cardiomyopathy causing the PVCs in the early stages? I think one parameter which you must see is the LA size. If your left atrial size is normal, it's the PVC rise and act early. It is not that if a patient has 10,000 PVCs, you want to jump in quickly and do an ablation. So I think thank you so much, Dr. Neeti, for the presentation. I think I'm being a bit, and may I tell you to invite none other but Dr. Vanita. So I think all of us are well aware about Dr. She's a pioneer in physiology with women. She's an expert in leadless pacing other than other, and as I showed that she was also on the guideline of 2023 guidelines for cardiac physiology. That sums it all, and let's hear from her.
So much kind introduction, really my day. And in stage with Aparna and Neeti, all three of us have trained from ESCOT, Makkah and Metrophysiology, and we are so proud of it. Thank you to organizers for inviting me here, and in the interest of time, my presentation with 3 B's. I'll be brief, I'll be bright, and before you know, I'll be gone. So, he's not given me the, I don't know how to work this out. Yeah, green button, I'm trying to press the green button only. Case report, to interest all the intervention cardiologists here, a 53-year-old male, diabetic, hypertensive, occasional smoker, typical history of acute MI, 2-3 days, showed 28% ejection fraction, 17 LE, and ECG of the patient. What would you do next? Of course, and LED is 100% blocked. Intervention colleague opens it. It's a beautiful result of a flowing LED. Patient is ready to go home and goes home with this halter. So as the things are going by, it's to have some ectopic activity of topics which are coming into a degeneration to a polymorphic VD, cardiac death. Only difference between an SC, right? And you do not wake up from this. And this is one of the very common cause of sudden cardiac arrest, and it has been a sudden silent killer in a lot of people, even with our past President Kalam Saab died in a meeting like this, delivering a lecture, and he died of sudden cardiac arrest. Nobody gave him a CPR. So we all are associated with this term of sudden. It is arrhythmic death, which causes a very impact on life and different substrates. And this study shows the big picture of SCT. Where should we be? Well, in the coronary armamentarium, in ARC we working more because we are the diabetic capital. Diabetes is the most important causative factor in coronary artery disease. And with the armamentarium of the coronary artery disease and the trials which have come in like MADIT and MUST, we know that there is a high risk in post-MI for sudden cardiac arrest. But the biggest challenge is the population. So you have to screen the general population also, because that becomes the subject which are, they do not have sudden cardiac arrest. We have data from China. India, unfortunately, we just have one study from my friend, Dr. Haigrave Rao, and it shows that southern India gives about 10% overall mortality because of sudden cardiac arrest. It's an old study, but this is the only data from India which is available. And how do I play this? I'm going to show you a football match. Can you play this for me, please? Yeah, thank you. Football match. I'm going to show you a football to make it in the atmosphere in the player number 29. A young fellow, well maintained, not he's playing, he's laughing. And well, he has a fall. Just collapses. And unfortunately, he did not survive this, because sudden cardiac death, this is how it attacks. Can you play this video for me, please? Thank you. Arrest occurs, and the heart, which is from the 5th week of pregnancy till we breathe our last, it just goes away. Defibrillation is the only option. And defibrillation granted as works to save the patient, the shock whenever the arrhythmia occurs, and saves the arrhythmia this is through the defibrillator. The patient has monomorphic ventricular tachycardia. It analyzes it, reanalyzes it, delivers a shock to convert the patient back to sinus rhythm. Another football match, well, this player falls on the ground, and look at this. Just look at this. He receives a shock, and within the matter of seconds, he wakes up and he's back to the play. So this is how ICD saves. So when of life, do we have to see where we should implant wherever is a high risk place? And if you look at the data of men versus women, well, coronary artery disease is a main factor in men. However, dilated cardiomyopathy and coronary artery disease form the very high group in females. And there are other groups, both in men and females. Well, primary versus secondary prevention, the only difference is that in the secondary, if you wait for an event of sudden cardiac arrest, you may never be able to save the population, because out of hospital survival rate, even in United States of America, is hardly 8%. We've had data coming up from MADIT-2 and SCHEF trials. MADIT-2 was all patients with extensive MI, 40 days after revascularization. SCHEF paired device therapy to amiodarone, and all of these trials they at AICD. Hence, the guidelines came ischemic cardiomyopathy, and there are trials of primary and secondary prevention for ICD therapy. But what is the numbers? We are so lacking in numbers. We lack, now we do have some government guidelines which are coming in, but there was this trial, published in PACE. They said, what is the most important cause, even wide? Why ICD? Well, it was that the physicians are unaware of the indications. So you need to create the awareness where the ICD therapy is required. And in case, primary prevention is not good enough in the country, for a 1.5 prevention, where we look at Sukkar patients with more symptoms, with a history of syncope, to them the devices. Now, some of us still say that Indian patients on data from outside India, why should we give them ICD? This is in data, Indian Heart Journal, about from all medical science, about 145 patients of trial criteria. 3% post-MI. This data collected and they compared it to the therapy model of MADIT, the group and devices. They compared it with that. What did they find? They found that we had younger patients, we had patients better controlled with diabetes and hypertension, we had patients on better drugs, inhibitors, anti-platelet drugs, we had that. Despite that, the mortality in our 69% as compared to the MADIT therapy group, 1%. So note that Indian patients. Modeling we can of course decrease the and that is what it has done. Incidence of sudden cardiac death has actually decreased, and we have a additional imaging modality. Earlier we used to only now we look at cardiac MRI, at the amount of scar, how big is the scar in the heart, and we look at cardiac PET also, revascularization for hibernation and everything. Then we decide. The genetic analysis actually very important, and it has become very well available now in India, and we can take the advantage of that. So in the ICD, the class 1 recommendation of SCD in ischemic heart disease patients. Well, ejection fraction cutoff is 35%. When there is no or minimal competing reason for mortality to the patient. Having said everything, just look at this. This is the sad part of the cardiac arrest in our country, how population takes it. This is 20 years old young female, 2 episodes of syncope. I documented this on the Holter. She has polymorphic ventricular tachycardia, and she has extensive ventricular ectopic activity. I told them, please get the ICD done. Got the genetic studies done. She had a malignant gene, heterogeneous malignant long QT. You know what her father said? Abhi to iski shaadi karni hai, doctor sahab. And we lost her 1 week ago, sudden cardiac death. I gave her this 4 months ago, I told her that she should get an ICD. So this is the situation in our country. Let's pledge to change it. Much for your patient care.
Thank you so much. I think we will have only one question for you.
Sure.
When you see a patient of non-ischemic cardiomyopathy versus ischemic, I think all of us understand ischemic, we jump to consider. In non-ischemic, has practice changed in considering an MRI today to evaluate? I mean, can you talk about that?
Absolutely. In non-ischemic cardiomyopathy, I get the scar burden. If the scar is huge in non-ischemic cardiomyopathy, for ICD is low. But in case the scar is small and ejection fraction is quite well maintained of 30%, I put the guideline medical. The newer drugs, my next speaker is going to discuss in detail, they do beautiful. I mean, really beautiful.
So I think what we were discussing a little while ago, and Dr. Vanita and I.
With AIG team, her topic for today is CRT in era of foundational 4.
Good afternoon. Getting very late. Let me thank Sujata Josna and Dr. Sarita Rao. Thank Aparna. Okay. I'm a doctor, and then I'm asked to talk about SGLT2. Though I was just looking up at the data, ARNI in era there are still trials, but if you get only SGLT2 impact, to inhibitors, there is no comparative data between with and without CRT. Then improvement in CRT hardware. Earlier, I was doing CRT case for 7-8 hours. Now I finish it in about 1.5 hours, and I see the benefit in the patient. So now look at what are the care gaps in heart failure therapy. So you look at, this is a study which in 2019. So they included Asian Heart Failure Registry and they included Qualify Global and CHAMP HF Registry. If you look very carefully, ARNI is at that point of time, 2019, ARNI was there only in 19%. But beta blockers and MRAs have definitely given benefit for failure therapy came only after ARNI was given. So you know this paradigm HF trial, which has definitely shown benefit, companion trial. So and then you look at this data which came in 2020. You look at the percentage of patients who are completely treated. They are almost 12 to 14% of the patients who are not given adequate drugs. Of medical therapy for heart failure is CRT still required. That is so retrospective analysis of 368 patients with an LV ejection fraction of less than 35%. 56 patients had a left bundle branch block with QRS of more than 150 milliliters. Clearly see that at least over 1.2 to 5.7 months, 10% of the patients reversed. They became narrow QRS. Now, what are the factors of the care gap? The study care gaps showed that there are factors associated with suboptimal therapy. So, the non-use or non-intensification of guideline-based therapy, older age, heart failure, and vascular disease, history of stroke or TIA, and heart rate and blood pressure, creatinine, and GFR and potassium become the main drawbacks for giving an advanced therapy. If you look at this trial, this came in, this was published European Society of Heart Failure in 2022. Patients who were implanted with devices were excluded. This sacubital valsartan ARNI was paired with CRT. So there are two groups. Group 1 is eligible for CRT. Group 2, they were not eligible for CRT. So if you look at this trial, the patients who were on CRT definitely they had better reduction in left ventricular and systolic volume. So in this study, who are the better patients who were male gender, shorter heart failure duration? If you notice higher sacubital valsartan initiation dosage, that is one of the independent association with betterment of an LV ejection fraction. So MADIT CRT trial, heart failure class 3 with EF of 30%. And again notice, this is left. They had left bundle branch block, they did better with CRT. But, and then those who had tachyarrhythmias definitely required ICD therapy. So the percentage of patients who received ICD was 731 patients versus 1,000 patients received ICD. CRT. So if you look at this reverse trial, on and off, on patients did better. Meta-analysis of NYHA class 1 and 2 trials, again, patients with the all-cause mortality and heart failure hospitalization were better in patients who are CRT definitely reduced the LV size and LV ejection, LV remodeling. There was no significant change in LS size and diastolic periods. Guidelines put if the patient has a left ventricular ejection, left ventricle branch morphology, and the QRS duration more than 150 milliseconds, LBBP, then these are the class 1 indications. Then the other morphologies, wide QRS, ICD, and right bundle branch morphology are not yet clearly into guidelines. Then early intervention. How early is an intervention? When do you do? Symptoms of NYHA class 1 or 2. Patients with AV block, they definitely need a device. There are already trials which show that if you have a device and if you're implanting a device and have an ejection fraction less than 45%, then they need a CRT device. And timing of the procedure in relation to heart failure admission, this I talk a little bit more. Hypertrophic cardiomyopathy. And then to early intervention with regards to timing of the procedure. So there is no definitive guideline to say what time you should implant the device, whether it is 6 months, whether it is 1 year, 2 years, 4 years. The disadvantage of waiting is LV starts getting remodeled. There is, as you go on waiting, left bundle morphology worsens and LV starts dilating. So, and then this remodeling, if you have a patient with a LV size of 7, 8, that patient will not get a benefit of either a CRT or an ICD. So these trials, timing of cardiac resynchronization therapy, this is for European society. This is what I am talking about is all patients are on therapy. So as you go on waiting, the symptom benefit on heart failure hospitalization, total mortality, and recurrent heart failure hospitalizations, everything worsens as you wait. So whether you do it during hospitalization or after discharge, it is early implantation strategy will be better. So who are the patients who will benefit? Again, coming back, left bundle block, QRS duration of more than 150 seconds, females, non-ischemic cardiomyopathy, these are the patients who will benefit. So who are the patients? In 2024, ACC expert consensus decision, after CRT, after drug optimization, if the patient still has a wide QRS and a left ventricular low ejection fraction, this is the patient who will go for a device. So this is by none other than Kanethal and Logan. This is reported 24. So what he says is real world data suggests survival benefits with CRT even in the era of GDMT. So this is my last case, last slide. Be aware. Or even if you implant your patient with a CRT, even if you put them on adequate medical therapy, keep a good follow-up. We have a good device clinic, so the workup done by the device physician assistant is extremely good. So I would, this patient, we implanted a device, she is on adequate therapy, and she comes back at 6 months down the lane. Luckily, my device person took a native ECG. This patient she is a responder. Definitely she has responded. And then her QRS is narrow. So we have put her back and programmed her to a single chamber ICD, and we have kept her on medical follow. This is my team. Thank you.
that one must. A reason also here I would like to say is when you see an ECG, you don't jump on a single ECG to implant a device. It could be a rate-dependent evidence if the patient had that point in time. Always look for more ECGs and data to put the device in. I think that was a fantastic talk. Thank you so much, Dr. Shirin.
Session is being closed.
Thank you, everyone. Moving on, the next session is Leave Nothing Behind. I invite Dr. Mahapekar Mashadi sir, Dr. Hemant Kumar Behra sir, Dr. Kavita Tyagi ma'am, Dr. V. Sujata ma'am, and Dr. K. Gopalakrishna sir to chair the session. First talk will be on bioresorbable scaffolds, lessons from failure to come back by Dr. Priya Pamelkar.
Good afternoon. Now we come to the last session of this exciting conference. And I'll invite
a very good afternoon, everyone. As it says that this is the last session and everyone is keen to get on with their lunch and move ahead to their respective destinations. So this is about the bioresorbable scaffolds. We all know that in our practice we have seen a great shift to young MIs. So similarly, there has been a tectonic shift in the Indian CAD population where now, as against 1990s, in 2023 we see 40% people who are below the age of 50 years. So when you see these young people with MIs, I feel I've crossed that age, so it's okay now. So is DES the holy grail of PCI? And this has been bothering most of us. And every time you tell a young patient that you may require a stent, he keeps asking you the question, can I not get away without a stent? So we have learned to live. We have seen that stent implantation is followed by inflammation. Eosinophilic infiltrates have been seen on autopsy studies. And as against the bare metal stents, we know that the drug-eluting stents, there is a delayed healing. Event rates beyond 1 year in all durable polymer DES, we have seen that beyond 1 year, there is a 2% annual event rates. So from 8% goes up to 17% at the end of 5 years. The stent-related events continue to accrue at the rate of 2% per year between 1 and 5 years, and in all the post-PCI metallic stents. So you see that there is a major adverse cardiac events which are more in patients with the bare metal stents, little lesser in the newer generation stents. In both the MACE as well as the TLR is seen higher. So using always a metallic stent may not be a good strategy, and we must have a suitable alternative available for younger patients especially. The BRS alone can deliver this promise of leaving nothing behind. And as you can see these OCT images, after a few years of implantation of BRS, you can see that the luminal gain is more and you can see a smooth endothelium behind. So these patients, the luminal area after a bare metal or a drug-eluting stent, it is reduced. But as against that, in BRS, after the 2 years, when you can see that the stent scaffold is resorbed, you see that there is an actual increase in the luminal area because the stent scaffold is resorbed, you see that now the vessel has got back its vasomotion. So the promise of BRS was tempered by the earlier clinical trials of stent. Now the absorbed stent was pitted against Xience, and you saw that there was an increase in the target lesion failure rates. Also, the 4-year outcome, again, there was an increase in the probable and definite stent thrombosis rates as against the Xience. And hence, this particular stall was there in the BRS, technology. And it was all because it was the first generation biovascular scaffold. So you know that this particular scaffold, it was bulky, it had compromised radio opacity, there was a limited size matrix, there was storage problems, shelf-life problems, and you needed an IVIS or to check the good apposition of the stent so as to prevent the stent thrombosis. And I think at that time, imaging was not that rampant as it is today in India. So despite better patient and lesion selection in Absorb 4, compared to the Absorb 3, the adverse outcomes still tended to be greater with the biovascular scaffold than with the cobalt chromium stents. So what we actually needed was an improvement in the device technology. We needed thinner stent struts and a better technique as against the previous one. Yeah, thank you. So what are the presumed specific mechanisms of this increased event rates? It was basically the mechanical issues, the strut thickness was higher, the thrombogenicity of the bioresorbable scaffold material was higher, the duration of bioresorption, encapsulation of the stent struts before the so that the late stent thrombosis should be lower. And how can we improve all of this? So improve the technique or the patient selection, the PSP, the imaging, and better DAPT, improvement of the device, thinner stent struts were required, and there should be an improvement in the mechanical properties of the device. Now, bridging this gap, you have the Meris 100, which is produced by the Merrill company, which is an indigenous Indian company, where you have a combination of both the multi-link and the open cell design. The stent strut thickness is lower as compared to the Absorb. The entry profile, the crossing profile is 1.2 millimeters, and it has better edge design where you have 3 couples of dots which tell us the 2 ends of the stent struts, and it can be kept at the room temperature. So this is what the Meris stent looks like, where you have the closed cells at the ends and the open cell in the center. The visibility is better because you have those markers at the ends. And if you see that the Meris degradation was better, the stent strut thickness, because of being lower, perhaps once it is deployed, the stent struts get very well embedded into the endothelium. And the OCT images illustrating the changes of the strut core appearance at day 0, and then you can see lower down at follow-up how smooth the endothelium looks. Besides, you can see the excellent radio opacity, which makes it easier for stent placement. And the similar configuration of triaxial RO markers on both ends of the scaffold, the distance at the distal edge of the balloon RO marker to the proximal edge of the scaffold is 1.3 millimeters. And in case you need to put an extra scaffold for a possible edge dissection, you have a choice where you can put the balloon marker tip at the RO markers, and that gives you stent edge-to-edge deployment. So this is how those balloon markers should be exactly at those RO markers. And then when you deploy the stent, you will find that the stent is almost just edge to edge. So this is what the toolkit looks like. The Meris stent comes with a pre-dilatation and a post-dilatation balloon. All said and done, aggressive bed preparation is the key of a good stent deployment in this case. So have a good bed preparation, and you deploy the stent and then pull it adequately and follow it up with an imaging. So there has been a clinical trial program of more than 2,000 patients, and the patients have been followed up, and you can see that the event rates have come down to 2%. The target lesion failure rates as compared to absorb in Meris is just 2% at 3 years. So in conclusion, the Meris trial, the first human evaluation of the novel second generation Meris 100 BRS with 100 micron strut thickness demonstrated high accurate success as well as long-term clinical success up to 3-year follow-up with very low MACE rates of just about 1.8 to 2% and zero scaffold thrombosis. All 4 modalities are consistent, demonstrating high efficacy of the Meris 100 BRS. So with that, I would like to say thank you for a patient listening at the end of the day. So thank you very much.
Priya, what do you think about your implanting bioabsorbable stent in the proximal arteries, let's say a proximal LAD, or are you comfortable?
I think we can do that provided we have a good imaging backup and do a good bed preparation. But yes, if the lesion has got calcium, then I would be worried about it. I would rather go for a metallic disc. But if it is a type A lesion, a proximal LAD lesion in a young male, then I think we can go where there is no calcium, no bifurcation. I think I would choose those kind of patients for bioabsorbable scaffold at this point of time. But I definitely believe that it is a novel idea and more science has to go into it. And maybe some years down the line, we would be discussing the same thing with a different thought process.
Yeah, I thought because of the drug-eluting balloons have become now
Yes.
competition
For the BRS, yes.
So proximal arteries are where we are implanting stents now. With the current preparation technologies, maybe we'll be looking at that.
Yeah. So it is a very dynamic field, and I think, as I rightly said, 10 years down the line, we'll be discussing different thought process. Thank you, everyone.
Now I invite Dr. Jagdishwari to talk about DCB, what is established.
At the outset, I'd like to thank the organizing committee as well as Dr. Sujata for.
Not cursing me for cursing.
So, and then I also want to congratulate you on conducting such a well-attended and it was really very well-organized conference. And I think the hospitality and the location and the scientific agenda, everything was very well planned and well organized, and you did a great job, ma'am. Thank you. So I come from Coimbatore, which is the city of Adiyogi, and I work for this hospital, Kongunad Hospital, which is in Coimbatore. Okay. So, and then, so my topic, as I said, it is drug-coated balloons and what is established. So I'm Dr. Jagdishwari. So I'll discuss this topic under the following heads. So why leave nothing behind? I think the previous speaker, she was talking on this. And then the technology of DCB, the technique of using a DCB, and what are the established indications as of now for DCB use, and then the future directions and a few cases if possible. So the rationale of stentless or leave nothing behind strategy using DCB. So as the previous speaker already said, so this drug-eluting stents, these are not the holy grail of interventional coronary interventions. So although they are the greatest boon we have ever had in coronary interventions, so but we see situations like younger patients who need, in whom we want to avoid metallic cage. So in these patients, it's better to have a stentless technology. And that too, although there is much improvement with the stents, the latest generation stents, there is still the heterogeneity of neointimal healing is always there. And we have adverse outcomes with the deaths, like the instant neointimal tissue, it is always there. Even though the antiproliferative drug is inhibiting the neointimal hypoplasia. And the triggers for thrombosis, such as the uncovered struts and durable polymers, and the late occurrence of neoatherosclerosis, which is very, very important, and the late stent thrombosis as well as the late stent failure, and the need for long-term dual antiplatelet therapy, especially in high bleeding risk patients. And then with the metallic cage, the vessel geometry as well as the biomechanics is altered, which we do not want in, especially in younger patients. And then the concept of metal allergy and recurrent ISR. So to overcome all this, we have the fourth revolution in interventional cardiology, the coronary interventions, that is the leave nothing behind strategy by using only DCB only strategy. So what do we achieve? There is no elevated thrombotic risk as seen with the temporary implants like BVS, and restoration of vasomata function, which is very, very important, especially in younger patients. And of course, positive remodeling with late luminal increase, which is seen in many randomized controlled trials with DCBs. And short-term DAPT, which is very, very important in high bleeding risk patients. And this is a Japanese registry data showing that the number of lesions as well as the number of patients who are being treated with DCB has been increasing slowly for the past few years. So coming to the technology of DCB, so this is a semi-compliant balloon which is coated with the antiproliferative drug as well as a carrier in an excipient matrix, and this is released homogeneously into the vessel wall during balloon inflation. So initially when the balloon is inflated, the drug is transferred. As soon as the balloon surface comes in contact with the vessel wall, the transfer of the coating occurs, and then the drug dissolves or elutes into the vessel wall. Drug gets absorbed into the vessel wall, and then it is retained within the vessel wall. It is distributed within the vessel wall. Here, there's a difference between paclitaxel and the limus drugs. Paclitaxel is predominantly concentrated in the adventitia, whereas the limus drugs are distributed evenly throughout all the layers of the vessel wall. It means that the paclitaxel is very much concentrated and slowly released, but the limus drugs gets diluted. So this is a picture showing the drug-coated balloon being deployed. So this targeted drug therapy, what does it achieve? It prevents smooth muscle proliferation as with this. The endothelial dysfunction is minimized, and most of all, it reduces or negates neoatherosclerosis, which is very, very important. So to be very effective, for the efficacy of the DCB only strategy to be very, very efficacious, we need that the drug should be rapidly taken up by the tissue, and then it has to be retained in the vessel wall, because the contact time is very, very short, only for 30 to 60 seconds, keeping the balloon inflated. So in order to compensate for that, the drug has to be rapidly taken up by the tissue, and it has to persist in the vessel wall to be efficacious. So the therapeutic efficacy is dependent on 3 factors. One is the drug use, second one is the carrier or the excipient, and the coating procedure. So because of its favorable uptake into the tissues as well as better retention, paclitaxel has been the drug of choice so far in DCB. And recent data also promote sirolimus because though it was in the earlier studies, the earlier formulations, the sirolimus was not, well concentrated in the vessel wall, and it was not persisting. The newer formulations like nano encapsulation and so many permutations and manipulations of the carrier, with that the recent data show that sirolimus is also very well effective. And both are lipophilic, and so they can be retained in the tissue for long. So number 2 is the carrier or the excipient. So these also play a very important role in drug persistence in the vessel wall, which is very, very important for the better outcome. So the coating, it has to be robust enough to envelop the drug uniformly and stably on the balloon, and then it has to be released, and the loss that during the transit during the transit the drug loss should be very minimal, and then there should be efficient transfer of the drug at the target site. So there are 3 generations of DCBs so far. The first generation and the second generation, paclitaxel was the drug, and the coating, first generation hydrophilic coating, and the second generation hydrophobic. Hydrophilic is the loss during the transit is more, but the transfer efficiency will be better. And second generation hydrophobic coating. So here the drug loss is less during the transit, but the efficiency of transfer is reduced. So and the third generation, as of now, more and more of sirolimus, and the coating formulations have been changed, and it has got both better transfer efficiency as well as retention in the vessel wall, and the loss during the transit is also less. So because so many factors are involved, like the drug, the coating, the carrier, the coating procedure, everything is involved, there is no class effect of DCBs. So, and these are some of the commercially available DCBs. The first few are paclitaxel coated, and the last ones are sirolimus. And you can see that the carrier is also different. In the paclitaxel coated ones, urea, shellac, all these things were used, and nowadays it is biodegradable POS. So what are the technical considerations? So first you have to select the patients as well as the angiographic lesions. So who are all going to benefit most with the DCB? So patients with multiple metallic stents implanted, and there are concerns about the long-term presence of metallic stents like young adults and suspected metal allergy, and also high bleeding risk patients. And the angiographic conditions, of course, in-stent restenosis, small vessel lesions, and osteal lesions, bifurcation, calcified lesions. There is RCTs are going on. So the potential benefits of DCBs are achieved only when the focus is on the lesion preparation, as we already saw. So the optimal lesion preparation, so pre-dilatation with the AC balloon and everything. And then
Dr. Mashadi is going to talk about that. Go on.
Okay, ma'am. So there are many options. So the choice is paclitaxel, and all this I already told you. And it has to be carefully handled. You're not supposed to touch the balloon, and then the transit time should be less, and the inflation time should be the minimum recommended by the manufacturer. And 2 millimeter proximal and distal to the bed prepared should be covered. And established indications are ISR, which has got a guideline support, and RCTs are there for small vessel, bifurcation, ACS, as well as high bleeding risk patients. ISR we already saw. And FDA has approved agent coronary DCB only on March 1st of 2024 for ISR. So ISR is the only guideline approved thing, and IVUS is highly recommended in cases of ISR where you're going to use only DCBs. And DCBs are similarly effective in BMS ISR, similarly effective as DES for less efficacious in DES ISR. And second one is the small de novo lesions where the evidence is building up. So I don't think I have time for all the cases. So other clinical situation, the next speaker will be talking. So like hybrid and bifurcation as well as long segmented lady lesions, DES as well as DEB can be combined. So what is established? Coated balloons are safe and efficient in treating ISR as well as small de novo coronary lesions. And lesion preparation is pivotal. And coatings other than paclitaxel need to be studied. And further studies with large sample size and longer follow-up period are needed for other indications. And it is very easy to use, just like any other balloon. And thank you all.
Okay. Thank you so much. May I invite Dr. Sandeep Bansal for the next talk, please?
Sir is professor and HOD, sir, of the Department of Cardiology at
Safdarjung.
GB Pant Hospital.
Safdarjung Hospital. No worry. Thank you very much, and thank you, Dr. Sujata, for having me here. There is bound to be a little overlap with the previous talk. So my talk is to tell you about emerging indications as related to drug-coated balloons. When this talk was, this is not moving. Okay. So when this talk was given to me, it took me back to my DM cardiology days almost 30 years ago. The stress and Benestent trials had just come in, and people were looking into the pathophysiology of restenosis. It was noted that almost 2/3 of the restenosis was because of recoil and negative remodeling, and about 1/3 was because of neointimal hyperplasia. The bare metal stents took away the recoil almost completely, but the neointimal hyperplasia persisted despite the drug-eluting stents. The only single class 1 indication, and that's a class 1A indication for a drug-coated balloon, is actually in stent restenosis. There is no other class 1 indication. They're all emerging indications, so to say. This is a very busy slide, but this traces the different mechanisms which have been used to treat the ISR, starting from intravascular brachytherapy to using cutting and scoring balloons, and using drug-coated stents and drug-coated balloons. Drug-coated balloons have been found to compare very well with drug-eluting stents as far as restenosis is concerned. It has also been found to be certainly better than the plain old balloon angioplasty. And therefore, the changes in guidelines are seen. The red and the yellow have changed to green. So it is important to define the ISR. It is also important to identify the contributory factors, and basically in neointimal hyperplasia, you need to use it. And you need to identify other mechanisms also. For example, if there's neoatherosclerosis, you need to implant a stent anyway. Now, the ISR data is based on two major things. One is this Daedalus study, which is almost a 4,500 patient study, which shows that the primary efficacy of the drug-eluting stents is slightly better, but on almost all other points, the drug-coated balloons score the same as the drug-eluting stents in ISR. For this reason, as I said, this is a class 1A indication. This point was also made out that only in this month, the FDA has approved for the first time in the US the use of a drug-coated stent, and this is a paclitaxel-coated stent. There is a state-of-the-art review about 2 years ago in the JACC interventions, which has given the uses of drug-coated balloons, and they say that though they are a novel therapy, they are only useful in ISR, but there are some other areas where they can be useful. The usefulness depends on patient characteristics, on coronary anatomy, and what clinical subset we are using them in. So beyond in-stent restenosis, they've been tried in small vessel disease, bifurcation lesions, and de novo coronary lesions. So beyond that, we can use in clinical subsets like acute MI patients. It can also be used they can also be useful in patients with high bleeding risk and also in bifurcation lesions, besides, of course, single vessel disease. So they avoid long drug-eluting stents, and they make the bifurcation strategy simple, and they avoid long DAPT and cause positive remodeling, as has been stressed in the previous two talks. This has already been highlighted. There's a great improvement in technology, and the important point is that we need sirolimus for drug-coated balloons, but it has only come now. The properties are different because paclitaxel fast tissue absorption, and the tissue resorption retention is for a longer period of time, and sirolimus, on the other hand, is a slow absorber and lasts for a shorter time. But as was said, the microcrystallization and nanoparticle encapsulation has made it possible for the sirolimus-coated balloons also to come in. So these are some of the Limus family balloons that are available now. Now, when we talk of treatment of small coronary artery disease, small vessel diseases, these are the drug-coated balloons which have been tried. There are several trials which are available. Although these are small trials, but they clearly show that as far as patients with high bleeding risk are concerned, or those without high bleeding risk are concerned, the primary endpoints are almost equivalent, both in drug-coated balloons and the DES. The major bleeding, understandably, is lower if you use a drug-coated balloon because you opt for a shorter antiplatelet therapy. So the important point here is that you need to have a very careful pre-dilatation, achieve a size which is 0.8 to 1 in terms of the vessel ratio. If you get a good angiographic result, the patient goes for drug-coated balloon. If the patient has a major dissection and a less than TIMI 3 flow, the drug-eluting stents have to come in anyway. Now, these have been used in patients with high bleeding risk. A single-center trial shows clear superiority of drug-coated balloons. The thing that we have been afraid of is actually dissection, but it has been seen that most of the dissections actually don't end up in a manner. So this is the classification of dissections. I'm not going to go into the detail, but the right side of the slide shows that 45 out of 48 dissections actually ended up well with a good lumen. And when we compare these patients, when we compare the use of drug-eluting stents in large vessel, this is a meta-analysis which clearly shows that even in large vessels, the late lumen loss in drug-coated balloon scenario is comparable to the DES group, and so is the target lesion revascularization. We can see the bottom square is bar on the unity. So in trials, actually there has been no worsening even if drug-coated balloons have been used in large vessels. And there's another trial which shows that these are useful in stable coronary artery disease. They are also useful in large vessels in patients who have a high bleeding risk. And when they've compared vessels less than 2.5 versus more than 2.5, again, there are no major differences in the hard endpoints and major MACE as far as the drug-coated balloons were concerned. So as far as the bifurcation strategy is concerned, drug-coated balloons have largely been used for the side branch vessel. In the main branch, they generally advise only to use a drug-eluting stent. However, if you don't have any dissection, then even in the main branch, you can use a drug-coated balloon. This is data from a small registry called the Potsdam registry, which shows that target lesion revascularization out of these small number of patients, 38, was actually 0. And so DES in main branch should be the preferred option. Drug-coated balloon should be used in the side branch, particularly when there is an ostial side branch lesion which you have to tackle. Then drug-coated balloons are a safe option. In main branch, very few bodies recommend, and that too in the absence of a dissection. They have also been found to be useful in certain clinical situations, like in acute myocardial infarction. This is a busy slide, but this shows the number of trials which have been conducted, both in ST elevation MI as well as in non-ST elevation MI, and in terms of MACE or cardiac death or target lesion revascularization or late loss and DAPT, etc. They are extremely equivalent. And also in terms of bailout stenting, the DCBs fare pretty well even in acute MI situation. The major trial in MI situation has been the DEB-AMI trial. As we see, the clinical outcomes at 6 months have been pretty much similar as compared to the drug-eluting stents. However, when we compare the lumen, what was the MLD, what was the percentage of diameter stenosis, there is a significant difference as compared to DES or the bare metal stent. In NSTEMI also, they have been found to be useful and non-inferior to drug-eluting stents. The other area where they are emerging is the peripheral artery. And the Society for Vascular Surgery and ACC-AHA, they recommend endovascular therapy if you have a significant functional or lifestyle limiting disability. And when the pharmacological therapy or exercise therapy both have failed, the recommendations are that because in the long femoropopliteal segments, there is a high chance of failure of the nitinol stents, and in below the knee options, the stents are not. A full metal jacket was planted. The guys from the army in several meetings, those data can only come from the public sector. So the guys from army, if you ask me, yes, have you used a drug-coated balloon in the distal vessel? because it's a diffuse disease and the target lesion you've treated with a DES, yes, I have done that. The other thing is, as I said, if I have a bifurcation lesion, I want to keep my strategy simple, and the side branch has only osteal lesion within 5 millimeter of the ostium. That's the only area where there's disease. Use a drug-coated balloon. That's a better option.
Thank you very much for being part of our
So thank you so much, sir, for excellent talk. May I invite Dr. Mashadi?
Congratulations, Dr. Sujata, on this absolutely wonderful feast, absolutely wonderful academic feast. So at the fag end of the conference, I'm going to show you a few things about how to negotiate the learning curve in a DCB. Can I have my slides, please? No, not this, the previous one. Negotiating the learning curve, Dr. Mapaikar Mashadi. Okay, so there we go. So it's really nice to talk to an almost empty hall, but I'm going to keep it short and sweet and I'm going to skip a few slides. So the drug-eluting balloons actually came into our armamentarium around 2006. So why do you want a DCB? You want because there's no metal, there's reduced need for prolonged DAPT, repeatability of the procedure, which is very important, and reduced vascular inflammatory response. Now, most of the things have been spoken by the previous speakers, so I'm just going to skip over these. What are the indications they've been discussed? The established indications for DCBs are instant restenosis, de novo small vessel disease, and de novo bifurcation lesions with a small side branch. Complex situations, multivessel disease, PCI requiring multiple stents, multi-lesion PCI, diffuse disease, long lesions, unprotected left main, and CTOs. I guess I'm going to skip all this because it has already been spoken by my previous speakers. So in instant restenosis, the most important thing is there's less metal. You're not putting layers and layers of metal, no onion skin layers, less trauma to the vessel, you get a better luminal gain and less target vessel revascularization. In de novo small vessel disease, it is particularly subset, has a high rate of periprocedural and led adverse outcomes. So even with newer generation, DCB. Understanding what is an acceptable result. So what do you do for pre-dilatation lesion preparation? Use a semi-compliant long balloon. Again, pre-dilate with an NC balloon. Use of scoring balloons. Be very liberal in using a scoring balloon. Dissections, like I said earlier, are inevitable, and you have to use a 1:1 vessel dilatation. Calcium modification techniques, low tablators, lithotripsy, of course, orbital atherectomies are of course important, and imaging techniques are very, very, very important. Using a suitable single antiplatelet. So this is what his angiogram looks like. This is the diagnostic angiogram. And I'll just going to show you how we have treated. This is the RCA. This was the cause of his MI. So we offered him a high-risk CABG or a minimally invasive surgery, which he refused. So the plan was to do DS to RCA, LCX, OM, and ramus intermedius, and if possible, LAD. He was a high bleeding risk, concern for full metal jacket in RCA and LCX. So we did a hybrid process, what you were asking, Sujata ma'am, combination of DES and DCB to minimize the metal. So this is how we treated the LCX and OM, just crossed, pre-dilated. So the balloons over here which were used, the first balloon was 1/5, then 2/12. Gradually we have increased the sizes of the balloon, and then finally a magic touch was done. So this was the end result. So going back to the RCA, RCA was again pre-dilated with multiple balloons, with a 2.75, a 3.5 cutting balloon was used. Again a 3.5/40 long balloon was used for pre-dilatation, and distally a 2.5 cutting balloon was used. The long balloon dilatation. We implanted a stent in the proximal part, and then the distal part was treated with the drug-coated balloon, magic touch balloon. So here you can see the final result. Yeah, the second view shows you the final result. So in this, we had used IVUS for this patient. In 2019, we did not have OCT. We had used IVUS for this patient. The second case again is a 90-year-old active female, no comorbidities except acid peptic disease. She came with us with an acute inferior wall MI, and she was on pantoprazole. Now with a 90-year-old female who's about 35 kilos, giving any kind of DAPT or high bleeding antiplatelets will be a high risk for her. So there's only one trial which says, relevation trial, which talks about DCBs in acute coronary syndrome. So this is her left system, diagnostic angiogram showing her left system. And the RCA, as you can see, is totally occluded in its mid part. Here again, we had to do multiple balloon dilatations, and she was I had to do thrombus aspiration, pre-dilatation with multiple balloons, and finally we used a 3.5/40 magic touch balloon for her, and that's the final result. So if you have those vessels at 90, and if you can just be treated with a balloon, I think this lady is a really lucky lady. So third case again, excuse me. She had ACS, non-STEMI, and multivessel disease. She had a calcific long segment lesion, and the distal circ was totally occluded. So here she had a PCI to LAD with rotational atherectomy and a stent. She is a young lady, mind you. So this was the LAD which was stented. In circumflex, again, we did rotational atherectomy and then used a 3/10 cutting balloon. And this again is a long, the entire vessel was treated with a drug-coated balloon. Here again a high risk for bleeding. This gentleman who had a 43-year-old male with a recent intestinal obstruction surgery and who came with ACS. Here he has a distal RCA block and a circumflex lesion. So the RCA was treated with a DCB. In the interest of time, I'm just going to. And LCX was also treated with a drug-coated balloon. The LAD was stented over here. That's the final result. So what is important is use of larger semi-compliant balloons for lesion preparation. Like I said earlier, lesion preparation is the most important thing. Liberal use of scoring balloon or a cutting balloon to gain adequate luminal gain. Use of imaging and perform FFR guided for smaller stenosis, 30, 40, 50% stenosis to perform a FFR guided PCI. Using an adequate sized balloon. Adequate sized balloon means at least 1:1, and you have to check the end result with imaging. That's the only way we are going to be able to do a good angioplasty with a drug-coated balloon. This slide has been discussed earlier. I'm not going to go into the details. So this is the strategy for appropriate use of DCB and DS in the current practices from Jack. And this beautifully explains the entire system. So DCB only strategy for many complex lesions may be attempted, while a DS and DCB hybrid strategy may be chosen if there is a compromised result during the pre-dilatation. Decision on balloon size across diffusely diseased long segment can be difficult because of caliber changes. So imaging again is extremely helpful. Tolerance to prolonged dilatation is a major concern because all DCBs we have to inflate at least for a minute, 30-second increments. Adequate pre-dilatation, like I've been emphasizing repeatedly, is important. And DCB should be commissioned only when optimal pre-dilatation has been obtained. Dissections are inevitable. Do not ignore dissection. And whenever needed, you can convert to a DES. Conversion to DES is not a failure. Thank you very much.
Thank you so much. So in the interest of time, there are no questions. May I invite Dr. Sarita Gulati?
See, as long as there is no flow limitation, you can accept it. If there is flow limitation or intramyocardial hematomas, that is when you should convert to a DS. Yes, we subject them to an angiogram at least 3 months. Yeah. We are actually, we've given it as a thesis to one of our DNB students.
Potential advantage, the bleeding risk and special situations also like pregnancy. Of course, we need further randomized data trials to make this as a statement for the women and CAD. That is really good thing, and yeah, we really need more data for women. We can make a registry. Yes, we can have some common points so that we can share all our experiences there.
Thank you, Dr. Sarita. Thank you, my co-chairs. So I think the time has come to end the session. Thank you all for coming here and gracing our city of destiny. So now I pass on the baton to Kavita.
For Dr. Sujata. And all the best, Dr. Kavita.
Over to Delhi next year. Kavita.
So congratulations to ma'am, and thank you so much for providing this opportunity, and welcome you all to Delhi.